Okay, well, good morning, everybody. I would like to say this must be like the 25th annual, but I think our first graduating class was only that was Brian Edlow, person one. Okay, anyway, this is always an exciting time of the year. I know all the new interns are going to say, wow, amazing. Look at what they've accomplished this year. Like, how am I ever going to get there? But that's what all you guys thought when you started too, right? But you will, of course, all be there. And that's what's so exciting. It's so wonderful to watch all of you grow and blossom and become these accomplished speakers. And, I know that our philosophy, of course, is that we throw people in the deep end, but we don't do it without some water wings. And again, it's a moment to really thank all of the mentors from the administrative side and the academic side and all the people that support this internship program. And on behalf of Francesca and Jeff and myself, we are, this is really a labor of love and something that means so much to us. But as you will see tomorrow at Sparking Innovation, your participation in this internship is a commitment. It's a commitment, not just to come back and share and do things, but it's a commitment to the future. And it's a commitment to be the kind of leaders that you can be, to really make sure that medicine evolves to be patient-centered and to be about quality and service, not just reimbursement. So that is really our theme, and that is really the higher purpose of this entire internship program. And also want to thank our advocates who are here in force today. Get you started on the right path from the beginning. So remember, that's what we're here for. We're here to make a difference for the people we serve. And that's it. And all the other things that go along with it are gravy. So today, every intern will start their presentation with answering this first sentence. The most important thing I learned this year is, and so we're looking forward to hearing what that is. And then we have 8 presentations this morning, and then we have lunch, and then we have another 6 or 7. And then they put down that will have closing thoughts. Imagine that I would have closing thoughts. Okay. So anyway, again, so excited to be here. And again, big round of applause for all of our mentors who are here. Everything. And I don't know if Hope Wallace is here. Is she here? I want to also thank her for getting everyone organized for the presentations. I think that's another incredibly important part of this internship is, getting some strategies on how to present and how to make slides. It's, again, you're starting off, when you get to medical school, you're gonna be pish posh. Okay. Okay, without further ado, Marcello, are you ready to start? Okay.
All right, well, good morning, everybody. I'm so happy to start us off, and hopefully I can get us started off right by talking about really one of our main trials here at the BCC, and that being the ISPY clinical neoadjuvant therapy trial. So let's go ahead and get some.
Thing I learned.
Yes, so I'll touch on that in a bit, but I think the most important thing that I learned really is that a tool's power is only as good as its implementation and not just its accuracy. And I think this is really important in terms of process improvement and quality improvement. And my personal project will focus a bit more on that aspect of the trial. But before we do start off with that, I want to make sure to actually give us an introduction to what is ISPY. So the ISPY trial is a neoadjuvant clinical therapy trial. That means that we treat stage 2 to 3 breast cancer patients in the pre-surgical setting. And we have a couple goals that I want to highlight on this trial. We're primarily focused on maximizing the chances of PCR so that when a patient goes to surgery, we're able to find no residual disease left. And we're also really focused on improving the personalized healthcare aspect of medicine. This is something that's very near and dear to my heart because I wholeheartedly agree with Dr. Esserman's philosophy that we're really here ultimately for the patients and to improve the patient outcomes, the patient experiences. And I think that unfortunately in this day and age is something that can be lost on physicians and different individuals working in the healthcare space. So I'm so happy to be in an environment where this is a philosophy where we can really bring forward, and I can help to contribute to that in a meaningful way as well. So I want to talk a little bit about how we actually define patients on this trial and what allows us to actually focus on that first goal, which is maximizing that chance of PCR. And it really has to do with this idea of response predictive subtypes. So breast cancers are categorized by basic receptor subtypes. You have your hormone receptors, your HER2 receptor as well. But what we've gone ahead is on the ISPY trial, we've included additional molecular biomarkers that allow us to further refine these standard receptor subtypes into what we call these response predictive subtypes. And the data that we've gathered over time has actually shown us that by categorizing patients with their standard receptor subtypes, in addition to these molecular biomarkers, we've actually been able to lead to improved PCR rates, which is incredible, of course, for patient outcomes. And so eventually, when we actually have patients start on the trial, these response predictive subtypes are what define the actual types of treatments that the patients will receive while on trial. And then in addition to that, I want to focus on this idea of predicted residual cancer burden and escalation and de-escalation. So sort of this aspect is more concerned with the personalized healthcare aspect. And so we have this tool known as pre-RCB, and this is a tool that essentially tells us how much disease is left, and it actually helps to identify patients who have a high likelihood of achieving PCR based on meeting certain criteria and thresholds. And I want to highlight some of the clinical tests that are actually involved in this process. We take MRIs at critical time points throughout the trial, and we have a specific biomarker that is unique to the ISPY trial here known as the functional tumor volume. And it's actually this functional tumor volume that helps to inform decisions in terms of whether patients should be escalating or de-escalating by measuring decreases or increases potentially in the tumor density and the tumor volume. And in addition to that, we of course have a core biopsy, which will help us determine if there's any residual disease left. And so this pre-RCB tool takes the information from both of these clinical tests and puts it into an algorithm that essentially has defined criterias and thresholds. And if those criteria and thresholds are met, it's able to actually provide a recommendation that a patient should de-escalate early to surgery, or potentially alternatively escalate to additional forms of treatment as well. So this is very key and very important in our personalized healthcare goal within the ISPY trial. And my project will focus a little bit more on the return of results letter later. So you'll hear a bit more about that as we go on throughout the day here. So lastly, the ISPY trial has a lot of different facets, and it's quite a complicated trial. But I really wanted to focus on just noting a couple of the highlights that I think are important to bring forward of what we're doing with ISPY. Firstly, this idea of qualification and validation of new biomarkers. This is especially important if we want to continue using this research space to improve the standard of care process for patients. I think ultimately we want to take these biomarkers from this research setting and integrate them into the clinical setting to hopefully lead to better patient outcomes. And in that note of this patient-centered care, I want to highlight the actual patient-centered design and the structure of the trial in that sense. You know, we have treatment modifications based on response, and we're extremely focused on improving the access and experience on the ISPY trial. You'll hear several projects later today, OneSource, virtual informed consent. These projects are also focused on improving the patient experience while on this trial. And I think it really can't be understated, that patient-centered design of ISPY, and how ultimately what we're trying to do is inform and empower patients and clinicians to be able to make the best choices with the best available information possible regarding patients' care so that we can hopefully lead to the best outcomes. So I'll go ahead and I'll transition here to this idea of philosophy of what have I learned, right? I think this is such a critical question because there's so much opportunity for growth here in the BCC, especially through the internship program and the support that we're allotted through the mentors and through Dr. Esserman as well. So these are the 2 points that I personally wanted to focus on here. I mentioned earlier that a tool's power comes from its implementation, not just from its accuracy. And this is, I think, something that can sometimes be lost in the academic space. We're so focused on making sure that these tools actually work, which is an incredibly important step of the process that should absolutely not be undervalued. But I think it's important to realize, taking a step beyond that, that the ultimate goal is to find ways to bring this to the standard of care and to bring this into a wider setting where more patients can have access to these tools and more clinicians can have access to these tools to actually be able to use them. So this will primarily be the focus of my project as well. And in addition to that, I wanted to highlight another point here, that every great stride is made up of many small steps. As I mentioned earlier, there are so many projects that are integrated here with ISPY that you'll hear the interns speak on today. There's myself, Alyssa will be speaking on virtual informed consent, and Millie with OneSource. All of these projects are just small steps towards this greater goal of finding ways to improve the patient care experience and hopefully lead to better outcomes. And I think that's something that I've learned here, is that level of integration that all of these different research clinical trials have, and how we can bring them together to really lead to these great strides in medicine as well. So now I'll go ahead and actually talk a little bit about my project. So now that we've talked a bit about ISPY and we have some of the context behind that, I want to delve a little bit deeper into this idea of the return of results letter, or the ROR letter, right? So as I mentioned earlier, one of the main goals of ISPY is this idea of personalized healthcare. And the ROR letter, specifically the 12-week ROR letter, is a very significant contributor to that aspect of the trial. This ROR letter specifically is an IRB-approved tool that recommends treatment de-escalation or escalation. And I want to highlight a critical point as well, that it actually returns research data to patients. This isn't something that's incredibly common, but what we've actually found here through this ROR letter is we found a clever way to actually be able to use this research data in a meaningful way within the clinical setting by connecting it to patients as well as providers. A couple other notes that I want to make about the return of results letter is that it avoids complex terminology and enhances patient understanding. In addition to using these tools, I think sometimes we can get a little bit lost in the terminology, and we have to understand that we need to make these tools accessible and easy to use for patients, because the theme, as we've sort of talked about throughout the day thus far, is we're doing this with patient-centered care and patient-centered design in mind. So ultimately, a patient should be able to interpret the tools that we're using them in order to further empower their care and the decisions that they make. So giving a little bit more of the overflow of how this process actually works, as I mentioned earlier, when speaking on predicted residual cancer burden, we take the biopsy clinical imaging exam as well as the MRI clinical imaging exam, and we take the data from both of those exams and put them into our algorithm to determine if certain criteria and thresholds have been met to actually generate a decision regarding escalation or de-escalation in the form of the 12-week ROR letter. And I want to highlight that proper implementation of this tool contributes to not only personalized healthcare, but an increase in the likelihood of patient-positive care outcomes, which is highly critical and ultimately the goal of the ISPY trial and the use of these tools as well. But more on this idea of proper implementation, right? I mean, this is a problem that we noticed very early on in my time here, that because there's a lack of seamless integration between these clinical and research systems, we've actually found that even if this tool, and we've seen that this tool is very effective, even with its effectiveness, we're actually underutilizing it. So we have this incredible tool in the form of this return of results letter, but we're not maximizing the value that we get out of it because we're actually having issues with proper implementation of that process. So I wanted to focus for my project on addressing this problem. And upon discussion with my mentors, what I decided to do was to develop, implement, and analyze the results of a optimized 12-week ROR workflow. So this is essentially a quality improvement aspect of the trial that when implemented, ideally is going to lead to the following goals, which is an over 90% completion rate for the ROR checklist. And I'll describe a little bit more what that checklist is. It's essentially a form that allows us to quantify the use of the ROR letter and see in which ways it was used within the context of each individual patient and each individual time point. And additionally, that second goal being generating the ROR letter within 1 week of the last treatment of the block. This is especially important and I think should be highlighted, especially here, because we need to be able to have fast turnaround times for getting this data back. I think another important aspect of the trial is actually returning data quickly and effectively and accurately in order to actually make sure that we're able to optimize the care for the treatment, or optimize the care for the patient, excuse me, as soon as possible. That's highly critical here. And I want to make note of this actual image here. This is a little bit of a call forward, but we have a separation between clinical and research-based systems, and we'll come back to this at the end here. But I think this gap, which was this image very ingeniously sort of suggested here by Dr. Esserman. I mean, I think this very well highlights sort of the divide that we're trying to conquer here right now. So let me start off by actually presenting the workflow that we were actually able to develop. The first note that I want to highlight is that this was developed through discussion with a cross-functional team, which included clinicians, trial leadership, as well as site CRCs and research staff. This is very important because within the ROR process, there are so many individuals involved that we have to get a wide variety of perspectives from all the different teams in order to find a way that we can further integrate this and make this work for everybody involved. So there's a lot of jargon essentially on this workflow, but I want to go ahead and simplify it by perhaps noting one specific case here on the workflow. So in the case, for example, where you have pathology positive for disease or the MRI criteria is not met, you can go ahead and generate a preliminary ROR. And this is critical here because it ensures timely decision making, right? We're very focused with not just accurately returning these results, but accurately returning these results in a very good turnaround time in order to be able to make the next treatment decision, whether that means going on to surgery or whether that means receiving additional treatment in the form of different clinical treatments, right? So once we actually have this preliminary ROR, we can take this to the clinical team, and the clinical team is able to discuss this with the patient because ultimately we want to encourage those discussions as well, that the clinical team, the physicians, and the researchers are all very well connected to each other. And this ROR is able to generate that kind of discussion and help sort of recommend what the next course of action should be. And then, of course, filling in the ROR checklist. And as I mentioned earlier, this actually helps to quantify the use of the ROR and the decision-making process, which is critical for post-event evaluation of the data as well. So I want to focus here on the main findings that we had. So these were all taken from Q4 of 2024. Firstly, we found that all of the ROR checklists were complete. So this is great news. We met our first goal that we defined a little bit earlier. And we saw that this was great. I should note as well, actually, that this workflow was implemented here specifically at UCSF in the form of kind of a pilot study. So the data that I'll be presenting here will be first for what we saw at UCSF versus what we saw for that time period across different sites throughout ISPY. ISPY has 45 national sites, hopefully more to come, but just an additional bit of context there so we can contextualize this data. So we saw that these checklists were complete here at UCSF, but that there were several incomplete checklists across different sites throughout the country here. But I want to highlight this second goal as well, which was that we were able to meet that threshold of 7 days between the final treatment of the block and the ROR being generated. This was super critical and a very important part of the project as well, because again, we want accurate, effective, high turnaround for this data so that we can empower patients and clinicians to be able to make these decisions in a timely manner and have all the information possible to when the decision is made. I think that's important to note as well. We want all the information available so that these decisions can be made with all of that in mind. I mean, we saw that this was a bit faster than the average at our other sites, which was approximately 12 days. So I want to just mention some closing remarks here as well, primarily demonstrating the value and necessity of integrating these clinical and research systems. I think that's highly important. But beyond that, I think it's really important to note that the implementation of these research tools is critical to eventually bringing them to the standard of care. You'll see later on within the context of ISPY, as I mentioned, there's several other projects, OneSource and Vic, that will talk about enhancing the effectiveness or implementation of some of these tools in the ISPY trial. And ultimately, what I think is important to realize is that we want to make sure that beyond these tools just being accurate and effective, that we're able to optimize them in a way to actually be able to bring them into standard of care confidently so that clinicians can use them in an effective way beyond just the research setting as well. And hopefully, in terms of these many small steps leading to these great strides, we can eventually come to a point where we're able to bridge this gap between clinical and research-based settings. So thank you again so much for your time. And I want to give a special thanks to my mentors as well. Thank you.
Okay. All right. So everyone, don't go anywhere. We have time for some questions. And I'm sure Diane and Susie were heartened to see this presentation. Do we have a mic or, okay, want to hand it over to any comments from Diane and Susie, our intrepid advocates?
Yeah, Marcello, was there any one area of the workflow that you had focused on that was breaking down, that was causing, 80% of the problem?
Not very.
Oh, yeah, absolutely. Yeah. And I think really what we were trying to focus on resolving is this idea that the information just wasn't ready in time, because there's so many teams involved in the process of returning this return of results letter. And what we found is that where that breakdown was happening is this lack of having that information ready at the appropriate time. So even if all the tests were getting done at the appropriate time points within the context of the trial, actually getting the data put together to actually be able to get it into the algorithm and generate it on time was really where we were finding our problem. So we wanted to make sure to focus on that when we were developing this workflow.
And then, also trying to make sure that, okay, so like if I called up and said, the pathologist, and he said, oh yeah, there's tumor there, the report's not out. So from the quantum side, they couldn't officially say that because they, I just took it. But if I've talked to pathologists and they tell me it's positive, it's positive. They're not, they need to go on to the next block. So, but then I can tell the coordinators and they can fill out the temporary ROR. So, we originally, I think we talked about this, like we wanted to make sure that we weren't making a mistake, but we forgot that that would be a longer, more cumbersome process. So that didn't work. The other thing is, why Marcello is the that filling out that the checklist really is reflecting what the physicians and patients decide. Why is that so important?
Well, it's incredibly important because we want to actually be able to quantify and validate this as a complex biomarker, right? And in order to actually bring this to the standard of care field beyond just the research setting, we need to have data that actually shows how we're able to utilize this in a clinical setting and to be able to quantify essentially in a reportable way and be able to quantify that and say, hey, look, here's how we're using this and here are the results that we came from that. So we're actually able to eventually implement this into a standard of care setting.
And it's interesting because we're trying to figure out whether people are going to follow our recommendations. They do a pretty good job after block A, not so much after block B. So we have this, we have this QED for all you math fans, quality improvement for escalation and de-escalation, though in this case, that we review all the data every Monday. And that was sort of one of the main things of the retreat is that people obviously aren't so excited about giving AC. Fortunately, so that's actually led to a whole new reevaluation of like, well, is AC a really good rescue after block B? Or for whom is it reasonable and how are we going to move on? So it's exciting. Actually, that data, first we were saying, oh, we're going to punish these people for not following the protocol. And I went like, well, wait a minute. Let's look and see how good a job AC is doing. Actually, not so great. So it leads to change. Questions? Yeah.
Great presentation, Marcello. I was curious, one of the big themes of your presentation was implementation. So the goal is obviously to implement this workflow across sites and to be part of standard of care eventually. I'm curious if you anticipate any barriers to implementation across different sites and how you would overcome those barriers in the future.
Yeah, well, I chuckle a bit up here, because I think really what it comes down to is there's so many cooks in the kitchen, right? And it's this idea where when you have so many people involved, there's just so many people that you have to get on the same page. And another thing to remember too is that not every hospital and hospital system operates in the same way that UCSF does, right? So because ISPY is a national trial and we have 45 sites throughout the country across all different states. We're working with a tremendous variety in terms of the way that these clinical systems are structured. And we're trying to find a way that's general enough where this workflow can be applied nationally across all these different clinical systems, but you don't want it to be so general that it's not actually providing any guidance on how to move forward in these cases. So striking that balance is very important and very critical. And I think ultimately one of the additional barriers to this implementation idea is just the idea that there's so many people and that all these clinical systems are very different from one another. And I think that's compounded by the fact that we're not just talking about hospitals that are different hospitals within the same state or within the same local regional area, but in addition to that, we're seeing hospitals across entire different coasts, right? So I would say that those are our main barriers in terms of implementation. We started to work towards that. The ISPY clinical trial folks all met in March at what we call ISPY Science Day to kind of give a report to all these different sites of what's going on, what's happening with the trial. And thankfully, I was able to have the opportunity there through Dr. Esserman to actually be able to present and talk about the workflow and this optimized aspect of the workflow and be able to bring that to different clinical research coordinator teams and actually start that discussion of how can we properly implement this and what are ways that we can further improve this so that this essentially tool, which is what it is, can be used more effectively at your site, regardless of whether or not the clinical systems are exactly the same as what we have here at UCSF.
And regardless of where you are, state, city, hospital, the goal is better communication.
Absolutely.
And that's really the key, is that people, and again, it requires disparate teams to talk to each other frequently, which is why we're all going to be in person this year. Yes. Okay. So
all about developing those relationships.
That's right.
Yeah.
Amazing presentation, Marcello, like so eloquently presented. I had a quick question, and this concept of positive patient outcome is just such a interesting thing to me. And in the spaces I've been taught in public health and whatnot, there's this concept of asymmetry in knowledge between the patient and the provider. And so there's a lot of conversation about, do patients want this extra data? Does it scare them if they don't understand it? And just this concept of maybe, is it easier for patients to just trust the provider and not get all this data? But I would love to hear how you kind of enter those spaces and discuss how you feel that these extra data can actually increase that positive patient outcome. And
yeah, well, I mean, that's such an excellent question. And I think we have some individuals here with us today that are so incredibly able to answer this and speak on this. So I'm wondering if, Diane, you'd be able to give your perspective and your thoughts on this.
Oh yeah, they didn't like the letter we wrote. They rewrote it entirely. So there we go.
So there's actual data that shows that if patients are involved with their own care, in this case, it was through patient-reported outcomes, like even filling out a simple survey, that their outcomes were better. So when I first started as an advocate over 20 years ago and talked to women, they were like, just tell me what to do. Just tell me my treatment. I never get that anymore when I'm talking to newly diagnosed patients. Everyone wants the information. And we as advocates always say, give them the option. They can always say no. You're not going to get many of those, but give them the choice. But information is power when it comes to breast cancer treatment.
And one of the things that we did, so this return of results process was genius, and it came from our central IRB chair, Brian Moore, and as a new way to return research results. And so we have to meet a criteria, which means that the data is actionable and that it's reproducible. So you can't give research results that you have no idea what they mean. So, but in that context, right, that you can return that. So part of the process is at the beginning, and these took us like at least 6 months to argue about, is here over the course of the trial is the information you're going to receive. And at these junctions, this is what you're going to hear. And we detailed all the thing, what is an MRI, what is the ROI, what each thing. And so we state that. And it was, and, Linda Newhouser in particular, helped us with that 8th grade plain language language to make sure that it came across that way. But someone needs to write that up actually. But it is, I think it's a really clever process. And maybe Jeff, I'll give you the opportunity to make the closing comment, because this process really is a shared decision-making tool, right?
Yeah, I'm excited to hear about return of results, and I assume that's going to become a standard in clinical trials. I mean, that's always been a concern of patients.
Any day now. Yeah.
No, that's always been a concern of patients, that they willingly join clinical trials. Usually, and this is a big issue, is there's something called therapeutic misconception. Patients often think that a clinical trial is going to result in better outcomes, and it may result in better care. That may be pretty well demonstrated. Well, you don't know that it's going to result in better outcomes. So the patient needs to be in equipoise. You need to be in professional equipoise in order to, do things like randomize patients. But they all want to know what the results are. So really, they're participating a lot of the time altruistically, like for the sake of, future patients, et cetera. But they all want to know the results. And so, I mean, it's a huge challenge to communicate technical information. And there are some patients who are, the evidence would suggest there's actually, even today, I think a considerable minority of patients who are called, information blunters, where they're finding it distressing to have too much information, and so they are trying to actually actively suppress information. And you can respect that. I think ethically, you can approach patients and say, we have this information. If you don't want it, we don't have to give it to you, or you can ignore it. But yeah, I'm excited about this return of results phenomenon.
Just for all the new people here, so ISPY 2, the trial itself would figure out who was having the best response, and the next person coming into the trial would get a better assignment because of that. But that's not particularly personalized. And what we really wanted to do with 2.2 was give people personalized information. And I think this is why people like this trial so much, is that no matter what, whether you're on the control arm or whether you're on the active new agent addition of new agents arm, that no matter what, at certain junctures in the trial, we're going to give you information that tells you about whether you should stay on the medicine you're on, or where you should move to the next block, or whether it's been so good you can go to the OR, potentially skipping therapy. So it's an experiment in trying to figure out how to personalize everybody's therapy within an ongoing trial where you're evaluating new agents. That, I think, of all the contributions we've made, is the most important. So it's a really important experiment that so far seems to be working. Marcello, thank you so much. So awesome. On with the theme, Alyssa. Pama has talked to us about the ISPY virtual informed consent.
All right. Hi, everyone. I'm Alyssa. Today, I'll be talking about the ISPY virtual informed consent. Just to start off, one thing that I learned this year is to be confident in what you know and always be open to new ideas. Now, Marcello explained the ISPY trial very well, and I'm going to be focusing specifically on the consenting process. So the ISPY screening consenting process before could be overwhelming and intimidating for patients. This was because they're often told about this trial right near their diagnosis, and it could be the day of their breast cancer diagnosis. They have to review lengthy screening documents, and it's just overwhelming in general. With ISPY being a great trial, there are many parts to it, but they don't need all that information at once. So what we did to combat this was we first looked at our screening informed consent form, or screening ICF for short, and we shortened it from 16 pages down to 6 pages by eliminating all the information about treatment from the screening informed consent and really focusing on just screening, because we want patients to know that they're joining screening to determine if they're eligible for the trial. And once we do know that they're eligible, then we can talk more about the treatment phase and if they do want to move forward. Now, the next thing that was also worked on is we made a new resource for patients that was called the ISPY brochure. And this brochure was reviewed by the patient advocates and to make sure that it's a patient-friendly resource, and it condensed down the screening ICF to the main points that we wanted patients to know about ISPY. Just if they're interested, they can first look at the brochure, and then if they want to continue with consenting, then they can learn more and dive into the screening ICF. And now what I'm focusing on is our current project, which is our ISPY Virtual Informed Consent, or VIC for short. Now, the ISPY Virtual Informed Consent is an interactive patient support tool, which takes all the information from the screening ICF and creates it into an interactive learning module. And I'll let it introduce itself right now.
I'm Vicky, your informed consent coach. I will walk you through this process and help you decide if a research study is right for you.
Now, Vicky currently is multilingual. We have a Spanish and Mandarin version, and it is also accessible on electronic devices. So patients are able to view this VIC tool both in the clinic or at home with their supporters and family. And the main focus of this project is really trying to create an educational tool that can be used in addition to our screening ICF, just to help patients better understand what they're getting themselves into when they join the trial. Some additional features that we have in the VIC is check-in questions, and this is just to highlight the main points that we want them to know about ISPY screening and also to address common misconceptions. And we also have videos incorporated into it just so patients have a visualization of the process and have better expectations on what they're getting themselves into. So this is just a short clip about genetic testing during the screening and kind of shows what the visualizations may look like.
Effects of procedures. For genetic testing, some of your healthy tissue and some tissue from your tumor will be tested for genetic changes linked to cancer. If you want to discuss the results, your study doctor will talk with you about what they may mean for you and your family.
As you can see, this is just a short clip, but it also includes captions for patients and has a few other features. Now, after we completed finishing and creating the VIC, we decided to start a pilot study at UCSF just to gauge patient feedback and CRC feedback on our tool and test the integration into our current consenting workflow. In this UCSF pilot study, patients who are interested in ISPY or referred to the consenting process are randomized to either the ISPY standard consent only or the ISPY standard consent with the VIC. And after they complete this process, they complete post-consent surveys, and the CRCs also complete surveys to give feedback. How we integrated this into UCSF's workflow. So we first have the provider introduce ISPY in the clinic, and then they'll verbally consent patients to VIC. If they are interested with the VIC study, then a CRC will randomize them to either the ISPY standard consent or the standard consent with VIC. And then they will complete the consenting process. If they are randomized to the arm with VIC, they'll complete VIC before they complete and meet with the CRC to consent. And then after they've completed all of this, regardless of if they sign on the trial, they'll complete some post-consent surveys. So I'll go into the surveys in this next slide. So for patients, we wrote 2 different surveys. The first survey was given to all patients in the VIC pilot study. And this was just asking them the estimated time they spent meeting with the CRC, some content check questions, just so we could see if there's any holes or gaps that were missing from the consenting process, and then their overall satisfaction consenting onto ISPY, and if they ran into any difficulties. The second survey was given to patients who did have access to ISPY VIC, which was the patients with the standard consent and VIC, and they were asked how long they spent on the VIC, and then their overall content understanding, and if they thought the VIC helped them better understand the screening ICF. And then it also asked, did they prefer using the paper consent with the VIC, or if they would rather just have the paper screening consent. Now for the CRCs, they just completed one 12-question survey, just asking about how long their consenting process took with patients and their thoughts on the VIC overall. So it assessed patient comprehension based off of how many questions did they ask during the consent, Did they think they asked more questions when they did have access to the VIC, or if they asked less questions? Was the VIC easy to set up and send to patients? And also their overall satisfaction with incorporating this VIC tool into their consenting process. And we also just added a free response box for suggestions and any improvements they thought we can use to improve the VIC. Now, our current progress, so we started this pilot study in May 2025, which is very recent, but we've enrolled 4 patients. 1 patient was randomized to the standard ISPY consent only, and then the other 3 patients were randomized to our standard consenting process with VIC. Our target sample size is 10 UCSF patients, so we're almost halfway through accrual. And once we hit those 10 patients, we plan to incorporate the feedback from the CRCs and patients, and then expand to other sites. Our preliminary feedback from the 4 patients was, for patients who completed VIC, the average time of completion was 17 minutes. And there were some comments about some functionality improvements and slide design inconsistencies that they mentioned. For example, the continue button, sometimes it wasn't clear, or like they couldn't see it on the slide, and they didn't know when Vicky would stop talking sometimes if the captions weren't on. One positive comment that we did get from one of the patients is that they really liked how detailed the VIC was, and they thought it was really easy to use, and they liked having access to it before meeting with the clinical research coordinator. Now, from the CRC perspective, we also got feedback. They did mention that they wanted fewer checking questions in the VIC. They thought there was too many and that it was a bit excessive. And then also to remove any treatment details. We did have some parts that still included information about the treatment. And so we want to fully eliminate that so it's focused on screening. And then building on that, just shortening the overall VIC length, and then also agreeing with patients about a few slide design inconsistencies. But overall, for all the CRCs that did use the VIC, it was easy for them to set up and send to patients. For next steps of the study, we plan to, once we reach 10 patients, we want to take all that feedback, edit the VIC, and then resubmit for IRB approval. Then we'll start by expanding the VIC to the Utah site, and then hopefully moving forward, we can optimize the VIC further and then expand to all of our other sites. I just want to thank our VIC team, Samantha, Rachel, Tracy, Fuad, and Christos for helping me with this project and mentoring me through this. And then also Laura and Francesca for helping me develop this project, and the rest of the ISPY team and interns for making this year great. Thank you.
Job. And this is actually something that the FDA is actually really interested in having tools like this. And I think it's very exciting. So congratulations. We have time for 1 or 2 really quick questions. Yeah. Stephanie, where's our?
Was it complicated explaining to patients that you study that
of a study?
The process of a study?
So the question is, was it complicated to tell patients that they're going to be part of a study to study how to consent for a trial?
Of the 4 patients we got, since the providers were able to talk to them and introduce to them the VIC study before, we didn't get that many questions. But sometimes if we called them and we were like, oh, you're randomized to the standard consent with VIC, they're like, oh, wait, what study? But then we just reminded them that it was just an additional educational tool that they had access to, and it wasn't for consenting onto the trial just yet.
One of the things that's really nice is because this is all electronic, I mean, you can put it in any language under the sun. So it's really nice. And then don't forget that we're trying to have the advocate video, that says your commitment to follow up is so key. I think this is where it should go. Right?
For the pros, or?
No, it's just like, this trial is available to you because of everyone who's come before you, and everyone after you is going to learn what happens. So important that you keep in touch, letting us know how you're, what complications you have and what your follow-up is. We hope that you'll stay in touch. That's the most important thing somehow. 30 seconds or something, just a short thing, then I think it's a great place to put it. And they just setting it up from the beginning is that, their voice matters and it comes from the advocates, right? Okay, awesome. Wait, there's one more question, quick.
For people who use the Vic, like, at home or elsewhere, like, how do they ask follow-up questions? Like, what does that process look like?
That's a good question. So for when we consent patients, we'll send them the Vic link first. And in our standard consenting process, we'll set up a Zoom meeting with CRCs. So after they've completed the Vic, they can ask any questions that they have during that consent meeting.
And of course, to their clinicians, right? It's not replacing us, it's supplementing. And people like only remember, I mean, when you're just diagnosed with breast cancer, that's what you hear. So the next conversation, oh, I never heard of that, but it's not like you didn't talk about it, because you just have to realize people just can't necessarily absorb it all.
Would you also use this for the
use the mic.
Would you also use this for the consenting process for the actual treatment, or is this only for the screening?
So far.
Currently, we're still working on just screening, but potentially.
It's more complicated, but I think it is good. I mean, it will show us what people understand and they don't. All right. Thank you so much. Big round of applause for Alyssa. Fantastic job. So it's just so exciting to see how poised and polished everybody is. All right, Sarah Choi is now going to talk to us about some exciting things that we're learning about the MRI, and she'll explain all that to us in just a minute.
Hi everyone, my name is Sarah, and I'll start off with one main lesson that I learned this year at the BCC. And I think it's really just the importance of communication, both with patients and the provider. And as the last ISPY intern, a big part of my role is coordinating for patients and giving them the information they need and answering any of their questions and really raising any of their concerns to providers. And as Alyssa talked about, one of the ways that we're trying to do this is through like these educational tools through Vic. But in my project, I'm going to be delving more into the MRI imaging that we have been doing specifically for a sub-study of ISPY. And I've been looking at the changes in an MRI measurement called breast parenchymal enhancement in relation to estradiol in estrogen receptor positive breast cancer patients. So as I said, a large part of my role here at the BCC this past year was within the ISPY endocrine optimization pilot. And this is a study, sub-study of ISPY that is testing neoadjuvant endocrine therapy for early stage hormone receptor positive, HER2 negative breast cancer patients. So in this study, patients will receive an oral form of therapy for a duration of 6 months, and then they'll proceed to surgery. In addition to treatment, premenopausal patients will also receive ovarian function suppression through a Zoladex injection monthly to limit estrogen production by the ovaries. On EOP, the main way that we assess response for patients on trial is through imaging, and we have 4 MRI time points in the trial, which include the baseline MRI at screening, 3 weeks, 12 weeks, and at the end of the 6 months of treatment, which is at pre-surgery. So here you can see what that breast parenchymal enhancement or BPE looks like on MRI. The image on the left is actually a patient from the EOP trial, and you can see on the red arrow is pointing to the tumor itself, and then the white arrow is pointing to the right breast, which is actually the normal breast, but the gray area is the baseline BPE that this patient is showing. And over the course of treatment, you can see how both the tumor is reduced as well as the BPE at pre-surgery. So it's defined specifically as the increase in signal within the dense non-cancerous fibroglandular tissue of the breast on MRI. One important thing to note is that the extent of BPE can be highly variable. So here, these are images of healthy, normal breasts, and the extent of BPE can range anywhere from no BPE to minimal to moderate and severe. So one of my mentors, Natsuko, performed a previous study where she showed that BPE could serve as a predictive marker of treatment response for patients on neoadjuvant chemotherapy in ISPY. So in her study, she showed that when BPE was suppressed, it correlated with higher rates of pathologic complete response for patients who received neoadjuvant chemotherapy on the main part of ISPY. So on the image on the right here, the top row is showing a patient with PCR. And in addition to their tumor disappearing, you can also see that their BPE is reduced at the interregimen time point. On the bottom row is a patient with no PCR. And here is a representative image of patients in this case where BPE is not suppressed. So this was really interesting because it ultimately showed that BPE may provide really important insight into the way that the tumor is responding to treatment for patients on this neoadjuvant chemotherapy. In my project, I was interested in looking at what biological factors can actually affect BPE. And from previous studies, we know that BPE can vary throughout the menstrual cycle. And it has also been known that premenopausal patients have higher BPE levels compared to postmenopausal women. So with these findings, it has been inferred largely that hormones like estrogen can affect the level of BPE on MRI. So the goal of this study was to test this association between estradiol and BPE in hormone receptor positive patients on the EOP trial. In this project, we had a cohort of 73 premenopausal patients on EOP, and they were randomized to one of 4 study arms. So that included amcinostat monotherapy in addition to aromatase inhibitors like letrozole or CDK4/6 inhibitors like abemaciclib, as well as the EOP standard of care. These patients also got estradiol drawn locally, and that was completed monthly, specifically for these premenopausal patients. Another thing to note is that there were also various ovarian function suppression start dates. The majority of patients started before they started neoadjuvant treatment, so at the pre-treatment point, while some started at cycle 1 and cycle 2. This is a graph showing all of the estradiol levels over time, with each line representing a different patient. And you can see here that most patients have their estradiol levels suppressed while on treatment since they are on ovarian function suppression. However, we do see some patients who have high estradiol level increases during treatment. And there were a few patients who developed ovarian cysts and had to receive emergency surgery to suppress their estradiol levels. But the main takeaway here is that most patients on the trial will suppress their estradiol as shown here. So this is a graph looking at the association between pre-treatment estradiol taken at cycle 1, day 1, so before neoadjuvant endocrine treatment, compared to the baseline BPE. And here we're seeing a small correlation between the pre-treatment estradiol and the BPE. And this is to be expected as we know that estradiol levels do fluctuate during the menstrual cycle. And this is only one snapshot in time for both estradiol and BPE. So I first assessed the association between pre-treatment estradiol, so at cycle 1, day 1, and how that is associated with the change in BPE over the 6 months of treatment. And so while I did see that patients with low initial estradiol levels had a greater BPE reduction, this difference was not statistically significant. And then another analysis I did was looking at estradiol levels while on treatment. So that's from cycles 2 through 6. And it was shown here that patients with suppressed estradiol, so below 10 picograms per milliliter in the postmenopausal range, were associated with greater BPE reduction as shown here. So that was a 31.4% reduction for patients with suppressed estradiol compared to the high estradiol group, which suppressed by 21.7%. And then I assessed this association again, but with the FTV change or the functional tumor volume that Marcello previously talked about. But I was able to see that for patients with suppressed estradiol, there was a slightly greater FTV reduction over the 6 months of neoadjuvant endocrine treatment. This difference was not very great though, but still a significant p-value. I also did an exploratory analysis looking specifically at patients with very high increases in estradiol levels. And I was able to see that select patients with these very high increases in estradiol on treatment had a smaller FTV reduction. So this estradiol change was basically defined as the difference between the estradiol level at cycle 1, day 1, compared to the mean of the estradiol levels while on treatment. And estradiol levels with a very large increase of more than 200 occurred for 9 patients, and their FTV change was smaller at 67.9% compared to the rest of the group at 75.6%. In conclusion, we were able to see that estradiol suppression to the postmenopausal range while on treatment was associated with a better reduction in BPE and FTV in these premenopausal patients on EOP. And additionally, for the select patients with very high increases in estradiol, a change greater than 200 following treatment had a smaller FTV reduction overall compared to patients who did not have such increases. So the next steps are to adjust for variables like age and investigate other factors like Ki-67 and better really understand this interaction between BPE and FTV. And we also ultimately want to assess whether withholding ovarian function suppression is a safe approach in patients receiving novel and more effective endocrine therapy. I just want to thank all my mentors and ISPY team and the internship. Thank you.
That's such great work. And just struck me is that on that slide you had correlating estradiol and BPE. There's right at the baseline, there's a bunch of people where there is a high BPE and a low baseline estradiol. Important clue. What is driving the BPE? Are you guys looking into that?
Not quite yet, but that would be an interesting question to investigate.
Yeah. Because BPE is a big risk factor, breast cancer. Yeah. So there's the confounding of the measurement of FTV because of BPE, which clearly this is showing some of that, right? But then there's something else. Opportunity. All right. Any quick questions before we move to the next one? I love that. All right. Next up, thank you so much. Big round of applause for Sarah. To show there's so much opportunity in this trial because everything you look at, one question begets another question. This is job security, right? Okay. So next up we have Ladores, who's going to talk about, finally, I'm so excited to see the results on the CyTOF studies. Michael and Jill, the moment we've all been waiting for. Okay.
Hey everyone, I'm Ladores. So unfortunately, we still don't have results. We are super close to starting it though. We're super close. I'll talk about it as well into why we don't have results yet. But before that, one thing that I learned this year is that it really takes a village to make science work. So what do I mean by that? Well, we have the clinical research, and I get those blood samples in Spitzer lab, and I'm working on like the wet lab aspect, and to hopefully finding biomarkers and possible immune therapy treatments. So, oh, sorry. So yeah, so my presentation will be analyzing ISPY blood samples using CyTOF. If you were here last year, it's pretty much an update, but we got somewhere, so that's really good. So first off, what's ISPY and what's CyTOF? Marcello gave a really good introduction already. So ISPY, platform designed to evaluate multiple treatments simultaneously to improve outcomes in high-risk breast cancer patients in the neoadjuvant setting. And then CyTOF, it's a instrument that combines both mass spectrometry and flow cytometry, very hard words. It quantifies over 40 parameters or characteristics of an individual cell, and that basically allows us to observe a cell as an entire system. So what does that mean for ISPY patients? Well, one, it's high dimensional single cell analysis. So it's immune profiling for ISPY patients. Basically, how does your immune system respond to neoadjuvant therapy? Two, temporal analysis. So longitudinal tracking of immune changes throughout treatment. So how does your immune system look before, during, and after treatment? And then kind of combining the two together. Three, that's gives us possibility for specific individual treatment based on your immune subset. So, right, which treatments work best to fit your specific immune subset? So moving on to our experimental design. So first we would conjugate the antibodies, and basically that's attaching metals to antibodies. Two, we would titrate antibodies for best concentration. We're finding the best amount to use that gives us the best signal after or when we run CyTOF. Three, we would do a viability stain, so we're marking dead cells. We would do a soft fix of the cells, so we're lightly freezing the cells in place. And then we do an extracellular stain and an intracellular stain. So we're labeling the outside of the cell, and then we're going to label the inside of the cell. Next, we would do a hard fix. So we're locking the cells in place. And then after that, we would run CyTOF and then analyze the data. So that was the experimental design. And this is an example of what our panel would look like. I just got two from our intracellular and our extracellular. So basically we have our channels, we have our metal, protein, clone, the stock concentration that we get from wherever we buy it from, and then our titrated concentration that gives us our best results after we run CyTOF. Cool. So our extracellular stain, for example, we have the protein CD4. It would be on channel 145, and we would use the metal ND. And our best concentration that we get after testing would be 3 micrograms per milliliter. It's all the way on the right. And then it's the same thing for our intracellular. We just use a different protein like CD68, channel 173. We use the metal YB. And then our breast concentration would be 6 micrograms per milliliter. So that is like a small snapshot of our huge antibody panel that we have. And then moving on to analysis. So this is a paper taken from Felix Hartmann's 2019 paper. This is what you would kind of see after you standardize the data of CyTOF, and then we're like looking at it. We use Cell Engine. I have an example, but basically on our y-axis we have CD3, and on our x-axis we have CD19. Those are proteins, and you have your T cells, which are CD3 high and CD19 low, and then you have your B cells, which are CD19 high and CD3 low, as you can see over here. And that's basically how specific we can get with CyTOF, and why would why we would want to use the CyTOF machine in general. So this is a real example. I think this is from an experiment we did 2 weeks ago. So we have CD45 on our y-axis and we have CD15 on our x-axis. CD45 high, so the population on the left, CD45 high and CD15 low, those would indicate our T cells. And then CD15 high and CD45 high, I believe those are our granulocytes. So we can get really specific again in our, basically the cells that we're looking at in the blood of the ISPY patients. Oh, I have arrows. Cool. So future directions, kind of closing it out. We need to finalize the antibody panels. We're still titrating and looking for the best concentration for some of our proteins. And then the biggest issue that we have, and the main reason why we really don't have real data at this point, is our CyTOF background issue. So as you see on the right, there's a population that is not supposed to be there, basically. That can be attributed to non-specific binding. So basically, there is binding of proteins that, like, there's bindings of proteins that are basically like not even targeted for that protein. And so that's why we see like samples, some of these samples have like these background noise. And I believe we've had an issue with our red blood cells, and we've been having a hard time kind of lysing them and getting them out of the way so we don't have this issue. And then after that, really it's just to run the samples and get the data and then look at the data after that. Yeah. So here are my acknowledgements. Thank you, Spitzer Lab, especially Matt, Janice, and Shohini, and then of course the BCC program. Thank you.
This is, I think, an example of such an exciting technology, and there's so much, but it is hard to implement. And, you know, I think this is one of the companies that I think spun off of Matt's technology came to us and wanted us to pay to have this done in ISPY. I'm like, are you kidding? I need to wait to see that it actually works. You know, but it is, but it's interesting because it is so exciting. And so then the question is, you know, this is what makes research hard. Are you better off trying to get the big kahuna, get everything, the big project work, or should you streamline it to make it, does it matter how many you run? And is this just a background problem no matter what? And you just have to solve it and then all is going to be great? Or is this a function of how the samples are generated, frozen, prepared? Is this ever going to be something that's stable enough to really implement? I think.
Yeah, that's a very good question. So it's a mixture of both in terms of how the samples were prepared and also just trying to figure out the best way to overcome the background noise. We have such a huge antibody panel and some of them collide with each other. And so right now, the problem that we're getting to is once we solve a specific background issue, another one pops up. Or maybe if we solve, we get rid of a background problem, a certain population of the cells that we really want, like they just decrease drastically, and which we don't want. We want to look at that population as well. So it's been trying to find the perfect cocktail for it all, just for everything to work and just to get the data.
Yeah, Mike, maybe you want to make a comment. And we've been trying to figure this out for over a decade, right?
Yeah. I mean, I feel for you. I mean, it's a hard problem. I mean, one way people are looking at it now is if you kind of know where the background's coming from, to use algorithms just to ignore it. Basically, you may lose some cells, but like that population you had, if you know that's background and not a real cell with two stains on it, then you can gate that out, obviously, right? And then there's machine learning algorithms that people are looking at to try to do that in a more objective way as opposed to subjectively gating. Because you can just throw a gator on that and say ignore it, right? But to sort of take that population and other things that you may not see in that two-dimensional, because you have 40 dimensions to look at, and using machine learning to try to deal with that, knowing that it may or may not be a background issue.
That is a great idea. Yeah. I didn't even know that was a thing. So that's totally an option. I'll talk to Matt about that as well. I'm sure he's already looked into that.
So that's the best example of, okay, what should be our next steps?
Yeah.
What should we do next?
Just basically
Call a meeting.
yeah, call a meeting. Yeah.
But I think this is actually a really critical lesson, right? So that, I think everyone sometimes thinks they've got to solve all these problems alone, but we have so much collective knowledge, right? And you're doing this. We're going to have the same thing with the Hyperion staining for the background. I don't know that I care about the 40 background things. I want to know that I can get the 12 things to work that we do know. And there's in the meantime, you can get data from a critical number of things while you're trying to work out the other stuff. But as I say, everyone has to remember, this is for all the new people and for the people who are here. Remember, if you're struggling with something, this is probably not the first time this problem has come up, and someone somewhere in this collective organization has solved it. Time to bring people together. This is, I think so, Jill. Schedule a meeting with Matt for our 1:30 time meeting. So, right. So it is, I think it's so great and so exciting. We've been committed to this for a long time, and, companies have succeeded and died subsequently because of not the accuracy or the idea, it's because of the implementation. Exactly. Same important principle, right? So, yeah. So before you go, let's try and maybe next Friday, add Matt so that Dodge can come to our last meeting. That's a half an hour. We've got an hour and a half. Get them on for a half an hour. Okay. We want you to hear the conversation, be part of it. Okay. Thank you so much, Dodge. Awesome presentation. I'm not mad at you. I know, but it is, this is the promise that you just can't get around. Okay. So now moving on, our next set of presentations are going to revolve on sort of different aspects, like one of the terrible problems that happens is people can get spread of cancer to the brain. We have different types of cancers. We have lobular cancers. Then we also have some of the support services that we have to try and make the patient journey better. And we're going to have Simona and Alondra talk about that. So we're going to start now with Michelle Jayaraj talking about the breast to brain connection. Okay.
Can't believe it's already been a year since we were all in this room as first interns, but yeah, I think I've definitely learned a lot over the past year. But what I'm really going to take with me as I continue on, and I think Dr. Esserman really embodies this, is that when you're advocating for a patient, you'll never be in the wrong. And so as all of us are continuing on in medicine and trying to be change makers, there's going to be a lot of pushback. And so I think remembering that is going to be really important. Things are going to get tough, but they're going to, be so worthwhile when we remember why we're there. But yeah, previously Dodge came up here. He talked to us about how we can characterize the immune response. And now I want to delve into the cases where disease progresses beyond the breast. So brain metastases are a common cause of morbidity and mortality in patients with breast cancer. And about 30% of patients who have metastatic breast cancer will eventually go on to develop brain metastasis. So why does this spread from breast to brain occur so often?
The underlying mechanisms are complex and we don't really know the reasons why, but clinical presentation really depends on tumor size, location, and the amount of metastases. We also see that patients have challenging symptoms that really affect their quality of life and their activities of daily living. Things like seizures, severe headaches, changes in cognitive function. And historically, prognosis has been pretty poor. We see the overall median survival is less than a year. So the use of systemic therapies have also had a lot of pushback, mainly due to difficulties in permeating what's known as the blood-brain barrier. This is a layer of cells that protects the brain from harmful substances and toxins, but also conversely, it stops different drugs that try to enter the brain and target these tumor cells. Recently, in the past couple of decades, we've seen new medications on the market that hopefully are CNS penetrant, but our current literature and the retrospective cohorts that we're seeing now often predate these newer medications. On top of that, we see that patients with active brain metastases are often excluded from clinical trials. So this is a cohort that is pretty poorly characterized, really requires further investigation to understand what are the key clinical characteristics that make up these patients. So in recent years, I mentioned that we had advances in medications. We see this really in the HER2 positive context. The first line of treatment is often going to be trastuzumab with pertuzumab in addition to some sort of taxane chemotherapy. And this has really proven effective, specifically in treating patients who have had failed radiation attempts or in delaying the progression of brain metastasis. We also have newer antibody drug conjugates like TDM1, TDXD, and then these third category of medications, which are these small lipophilic molecules, tucatinib, lapatinib, and neratinib, which are HER2-directed tyrosine kinase inhibitors. When we look at the context of HER2-negative disease, the notable advancements are a little bit more limited in treating intracranial disease. But there are a few new medications like abemaciclib, which is a CDK4/6 inhibitor, that's specifically used in the context of HR-positive HER2-negative disease. And then when treating triple-negative breast cancer, we have the antibody drug conjugates sacituzumab govitecan, the immune checkpoint inhibitor pembrolizumab, and then recently we're seeing PARP inhibitors in clinical trials. So given the clinical burden of brain metastases and how different each kind of subtype responds to medications and how brain metastases progress, we thought it was important to ask what are the key clinical, molecular, and prognostic features of patients in this cohort, and how do they affect survival outcomes? We also took a stab at a secondary objective, which was to understand what are the risk factors that are associated with poor prognoses. So we first kind of compiled a cohort of patients who fell within these categories. So patients who had metastatic breast cancer, who had metastasis to the brain, and then were treated here at UCSF. And so we dug deep into a few of our databases, like the radiation oncology database, the pathology database, and then we did our own kind of clinical search. Then we did a detailed chart extraction where we pulled these kind of demographic and clinical data points like lab values, biopsy dates, follow-up dates, survival outcomes. And we ran this through a multivariate analysis where we tried to pull out risk and protective factors. So when looking at this cohort, we saw there was 507 patients who were identified and followed this criteria, majority of which were female. And then the median age of diagnosis for metastatic breast cancer was 53. Most of our patients were white and non-Hispanic. So when we delve into the clinical characteristics, we see that most of our patients had ductal histology. And then interestingly, for a molecular subtype, there was a greater representation of HER2 positive disease and triple negative breast cancer. And this kind of falls in line with what we see in literature because those subtypes often have this propensity for CNS development. And then when we look at the number of brain metastases at diagnosis, patients typically had 1 or 2 to 5. So this is really, I think, where the important data is overall survival. And I mentioned earlier in the beginning of the presentation that historically prognosis was just at under a year. And in our cohort, we're seeing that it's almost double that at 21.6 months. But when we break this down by subtype, we see that HER2 positive patients have a much greater overall survival compared to the HER2 negative cohorts. So it's 31 months for the HER2 positive patients. And that's statistically significant when compared to triple negative breast cancer and HR positive HER2 negative patients. If we break that data down a step further and look at it based on the patients who were diagnosed in 2015 or later, or their previous cohort, patients who were diagnosed from 1997 to 2014, we see that patients with HER2 positive disease and triple negative breast cancer have significantly greater overall survival. But this benefit is completely lost on patients who have HER2 negative disease, HR positive receptors. So what are the key takeaways from this? We saw that there is significantly higher median real-world overall survival in the overall cohort. We saw that HER2 positive disease in patients had significantly increased overall survival, but in specifically HR positive and HER2 negative disease patients, we see that there's no increase in survival when looking at the modern cohort. And this is because there were notable advancements for HER2 positive disease and even in triple negative breast cancer, but we didn't see this benefit in HER2 negative HR positive patients. I mentioned also that we did a multivariate analysis. And so the risk factors that came from that included triple negative breast cancer, having 6 to 10 brain metastases, extracranial metastatic breast cancer, and of course, the progression of leptomeningeal disease. But then when we look at protective factors, we interestingly see that HER2 positive disease is one of them, brain metastasis surgical resection, and then metastatic breast cancer diagnosis after 2014. So what does this mean for patients who have early stage breast cancer? We're seeing in this study that CNS penetrant therapies are effective. So why not use them earlier? We can start employing them in clinical trials, especially like ISPY. But unfortunately, when trying to target patients and try to see who is most likely to develop brain metastasis, it's important to recognize that this was a retrospective study. And so we're only privy to the data that's available to us. So our end goal is to eventually have a prospective study where we can collect blood and tissue and kind of determine what the correlative biomarkers are that lead this breast to brain progression. And then lastly, in catching these patients earlier, we need to understand what the screening guidelines are for breast cancer patients and getting brain metastases. And right now we don't have really any robust screening guidelines. So what that means is patients will only get a brain scan if they start to have symptoms like the severe headaches and seizures. And by that time, it's already, progressed a lot. So we need to understand what the current guidelines are and see how we can personalize them for patients who have HR positive or HER2 negative disease. Oops, sorry. And with that, I would like to thank all my mentors, Dr. Huppert, Dr. Krasnow, Dr. Esserman, and of course, my super serious
warning to all the new interns, better come up with a really good idea for the Halloween skit. Okay. Gotta keep up the tradition. All right. So, Michelle, that was super interesting. And, it's hard to know where, obviously the best results are in HER2, right? And what's characterized HER2 over the last, 5 years in particular, 5-7 years. The treatments.
I think we found a lot more of the smaller lipophilic molecules like targeted therapies that really can cross the blood-brain barrier. And we aren't really seeing this in HER2 negative disease. We have like tucatinib, lapatinib, neratinib, but we still have the same kind of antibody drug conjugates that we're using for HER2 negative disease.
Right. So probably because of penetrance to the brain, but also such, really better control overall. So again, that's one of the, HER2 is sort of one of the early targeted molecules. It's a true driver. That's just, there's so many more options, but it is very interesting. And we know from ISPY, right, that there's, independent of whether you get a complete response everywhere, the brain is still a rogue element. And we don't know how to predict it. But if we could, I mean, again, how common are brain mets alone? How common are brain mets alone?
About 30% of metastatic breast cancer patients.
I know, but if they, but to only get brain mets, it's not big, right?
I'm not sure of the number, but based on our study, I will say that I think most patients have had metastasis elsewhere in the body.
So that's actually really interesting because that suggests that the reason people are doing better in HER2 particularly is because we can control the HER2 positive disease elsewhere. In ISPY, about 4% of patients are at risk for brain-only mets. And that happens whether you have a complete response or you have lots of disease left. So so I think that to me tells the story that it's not just about penetrance in the brain. It's actually, if you can't control the disease elsewhere, it really doesn't matter whether you control the brain. But if you can control the disease elsewhere, then it really matters. So the better we get at controlling distant disease, the more important the brain is, right? That's really interesting. Quick question, time for one quick question. Okay, oh yes.
Great presentation, I really enjoyed it. So with these CNS penetrant treatments, what is the, I guess, balance between these neurotoxic treatments that kind of exist and then treating them as soon as possible? Is there like damages in treating them longer than you should be, or how do you kind of balance that treatment?
I think a lot of times, like when you look at therapies like radiation therapy, it's not very curative, right? It's like you're treating the symptoms, and sometimes when things get really bad and patients have these seizures and headaches and changes in function, I think you kind of do have to balance out like where is the line between helping out patients and also like, yeah, like you said, balancing the toxicity of medications.
I think this is it's a very important question. So like the tyrosine kinase inhibitors, the small molecules that penetrate the brain, they're treatment everywhere. So the fact that they cross the blood-brain barrier is great. It doesn't increase toxicity. It's just the same, right? So that's actually better. And being able to do targeted, radiation, cyberknife in the brain is great. It's very interesting that whole breast radiation, which is still being used, if you live more than 6 months, it really seriously impacts your cognitive ability. So you have to make a decision. I mean, this has been shown over and over again. And why you could maybe use it palliatively to just control someone's symptoms, knowing that they're going to live 3 or 4 months. But if you've got HER2 positive disease where you think you're going to survive, like I would be 100% against something like that, because you can survive, but then you're surviving as what? So I think these are very important issues, and there is data over and over and over again that shows terrible that is. For short palliative, fine. More than that, I wouldn't use it in the HER2 setting personally. Right, all right, fantastic talk, thank you. Moving on to our famous salsa instructor, Astrid Quirarte. Yay, everyone's going to be a salsa expert by the end of the year. That's the most important thing, isn't it, Astrid? Yeah.
Salsa researcher.
A salsa researcher, yes, absolutely. She's going to tell us about lobular cancer.
Hi, everyone. My name is Astrid, and one of the most important things that I learned this past year is the important role that physician researchers play in creating trust between the public and medicine. And that's a trust that's much needed today. So Michelle was talking about factors associated with overall survival, and now we're going to hear from patients themselves about the diagnosis and treatment of lobular breast cancer. So what is ILC, or invasive lobular carcinoma? It is the second most common histologic subtype of breast cancer and comprises about 10 to 15% of all breast cancers. On a histologic level, it is characterized by the loss of an E-cadherin protein that leads to a diffuse growth pattern seen here. And this creates a lot of barriers and challenges for patients. At the diagnostic level, there's a lower sensitivity of screening mammography. And in terms of treatment, there currently is a lack of tailored therapy and higher positive margin rates. And when it comes to surveillance, there's a higher propensity for late-term recurrences. And so with that, we decided to create a prospective registry that was going to longitudinally look at these outcomes. In order to do that, we enrolled patients through the participant recruitment program. And we identified participants with an ILC diagnosis on a pathology report. 1,300 patients were identified and contacted via MyChart. 294 expressed interest. Of those, 272 were deemed eligible. 179 have been contacted so far, and we had a 53.6% enrollment rate. And in terms of clinic screening and referrals, we screened the breast care center's schedule, and through that method, 8 were contacted and 8 were enrolled. At our annual follow-up, we interviewed participants, and our interview structure comprised of 60 minutes in length, and we included closed-ended questions that provided quantitative data of diagnosis, screening, local regional therapy, systemic therapy, and surveillance. And we also asked 2 open-ended questions, which was, how was your ILC found? And if there was anything else that you would like the researchers to know about diagnosis or treatment of ILC. In terms of our methods, for each study question, we had a quantitative and qualitative analysis. Our quantitative analysis comprised of descriptive statistics, chi-square analyses, and analysis of variance, while our qualitative analysis involved inductive coding from 2 different coders to develop unique themes. And in terms of our results, in this cohort, we had 93 participants that completed an interview, and the mean age was 58 years. In terms of tumor characteristics, we had 97 tumors in this analysis, and that's because 4 patients had bilateral ILC. 54% of patients were stage 2. The vast majority were ER/PR positive, HER2 negative, as is expected with ILC, and 73% were grade 2. We next asked participants how their initial ILC was detected. And so this is a graph depicting the method of ILC detection per screening method. And so for participants that were not undergoing any screening before diagnosis, all of them found their ILC through a physical finding. For those undergoing mammography screening, 52% were screen detected, while 39% had their ILC found through a physical finding. For the breast MRI group, 71% were screen detected, while 29% had their ILC found through a physical finding, and this group was also undergoing mammography screening. For the breast ultrasound group, 10% were screen detected, 35% had their ILC found through a physical finding, and 45% had their ILC found through a different imaging method. But as you can see here, this difference was statistically significant, and we have a large proportion of patients that are finding their ILC through a physical finding. We then asked those participants who found that physical finding, and 90% of them reported that it was self-identified, even though they were getting breast exams regularly from their clinicians before diagnosis. And one of the themes that came up at this point in the conversation was a dismissal of ILC symptoms by providers. So one participant said that her OB-GYN felt something, but the mammogram showed nothing, and unless it showed something, they wouldn't pursue anything further. And she pushed for an MRI because she knew enough about lobular and because she already had it. A different participant mentioned that no one really ever talks about how the flattening of the nipple could be concerning. Even though she brought that up to her nurse practitioner, she was told that everything was fine. And we also see this in the quantitative data. We detected a difference in the mean ILC tumor size found on pathology based on the method of detection. But there was no difference in overall stage, grade, or receptor subtype. And you can see that mammogram physical finding had a larger mean tumor size, and this difference was statistically significant. We then asked participants what local therapy was received. So 42% of them
said they received lumpectomy and radiation, while 7% received a lumpectomy alone. And then 26% of them received a mastectomy and radiation, and 25% received a mastectomy alone in this cohort. 30% of this cohort elected for a bilateral mastectomy. And some of the reasons that they mentioned for this procedure was having a bilateral ILC or a genetic mutation. One of the themes that came up at this point was an underestimation of ILC tumor size, and that impacted diagnosis and treatment. One participant said that it was originally thought that her tumor was 3 centimeters based on the mammogram, but the MRI showed that it was much bigger, so she was only offered a mastectomy at that point. And then another participant said it was really advanced by the time it was caught. They thought it was tiny on the mammogram, but then she had to get a mastectomy after a lumpectomy. Another theme that came up was participants receiving automatic mastectomy recommendations when they were diagnosed outside of UCSF. One participant mentioned that at a different clinic, her surgical team was not confident that they could avoid a mastectomy. And when she came to UCSF for a second opinion, she was able to receive breast conserving surgery with an oncoplastic reduction mammoplasty and able to clear her margins. For a different participant, she mentioned that the MRI gave her surgical team the confidence that they could do a lumpectomy. And she was really glad to have this option because when she was first diagnosed locally, she was only offered a mastectomy. We then asked participants what their current surveillance patterns were. And so 25 participants who did not receive a bilateral mastectomy mentioned that they were receiving mammogram surveillance. 23 participants said they were receiving breast MRI and mammogram. 13 were not receiving any screening. 4 of them were getting all 3 imaging, and 3 of them were getting mammogram and ultrasound. And one of the themes that came up was a desire for improved surveillance methods of ILC. So one participant, she received a bilateral mastectomy, and current guidelines in order to detect a recurrence for a participant like her, she would have to be conducting physical exams of the area by her provider. And she mentioned that, her providers didn't feel when she had 2 tumors, so how are they going to feel it now? If they do not know if they can, she doesn't know if she can detect it, if it comes back or not, just by feeling. A different participant mentioned that she feels like she should be followed by something else other than the mammogram because it didn't show up on the mammogram for her. She just wishes there was a different way to look for it. And that MRIs aren't the way to go, in her opinion, but she just wishes that there was something better. And the last themes, when we asked participants if there was anything else that they wanted to share with the researchers, was that they wished for better patient information on ILC symptoms, as well as improved awareness amongst providers. One participant mentioned that she didn't know that there was a breast cancer that did not have a lump, and so she started to educate herself on this. And a different participant mentioned that she wished more doctors were aware of how lobular breast cancer presents and that it needs to be approached differently. And so the key takeaways of this presentation is that 1, patient experiences inform, validate, and provide a fuller picture of the data that you're looking at. And 2, ILC is a unique subtype that needs specific research. 3, we need an improved awareness and enhanced patient education, as well as a need for tailored treatment strategies and imaging strategies. And our future directions with this project include further exploration of the themes that were identified, and then some of our ongoing ILC research that we wanted to share with everyone was FES PET imaging and its impact on ILC. And then we recently started the PLUM registry, which evaluates serial ctDNA changes in metastatic lobular patients. And with that, I wanted to acknowledge my mentor, Dr. Mukhtar, the entire lobular research team, and the BCC internship.
Okay, great job. Okay, we're going to open to questions. Catherine. Wait, let's get the mic so we're recording. So.
Wonderful presentation. I'm curious, 1, do we know what specific risk factors are for lobular breast cancer in particular? And 2, are there specific screening strategies that have been shown to be more effective, or is that still
like unknown?
We still don't have tailored imaging strategies specifically for lobular. And I think what's interesting about lobular is that there's still some heterogeneity. And so that's what we've been pushing forward in some of our retrospective analyses. So we have a paper evaluating recurrences, at least on the surveillance side of things. In terms of the screening before diagnosis, that is like an area that we were hoping to contribute with this study.
I think there may be an opportunity to really kind of rethink the thresholds, background thresholds and MR that may make that easier. I mean, I think of the things that we have, MR is the best. I'm gratified to see the data showing how terrible lobular is for ultrasound is for this, because this is a significant piece of misinformation that people think that ultrasound's like the solution for dense breast tissue, which it completely is not. Anyway, and that shows that there. But there is one kind of cool thing on the horizon, right?
So one other imaging technique that we have been exploring is FAPI imaging. And so please feel free to take a look at the research associated with that as well. And I think there's a researcher from Australia that he's doing a lot of work in FAPI as well.
Yeah. So what's very cool about this is that FAPI it's really for fibroblast activated protein, and it's really a particular, it's part of the fibronectin. It's sort of the scaffolding. And the fact that it shows up on these scans means that lobular isn't just floating out in the ether. It actually is part of a scaffold. And this is my own interpretation. It means that there is a highway, and that highway is part of the tumor. And they're now antibody drug conjugates that target it. So I am super excited about this. And we're working hard to get that into EOP and to, I just think it's really, next year is going to be lots of fun, right?
Hi, Astrid. One more question. Thank you. Great presentation. So I was wondering about the cohort of women who have been screened by mammogram, but their lobular cancer came up, was symptomatic, right? So they discovered it. Do you know when those people had their last mammogram? Like what mammogram screening schedule were they on?
Yeah, so as part of the study, it was limited to our 10-minute presentation, but we did collect the date of your last imaging scan for all of the methods that were shown in the presentation. And so we do have that. We also have all of the imaging reports from the date of their first, earliest screening imaging report we have available, as well as their first diagnostic imaging, because oftentimes when they switch from a screening mammogram to maybe a diagnostic mammogram, that's how some of the participants were screen detected. And so we have those reports available. So we collected the breast density, the BI-RADS association. And so more analyses are coming to take a look at the association between that, breast density, because that was also a theme that came up. So yeah.
So I think it's actually another really important thing is that if 50% of women today find their own cancers still, because there are some defects in screening. So this knowledge that flattening of the nipples, because the way lobulars sort of come in and sort of contract the breast, classic, people need to know about it, and it just needs to be more popularized. And hopefully this is one of the things that will come out of wisdom as well. Good. I mean, you should actually, even wisdom 1.0, it's really something that you guys should look. I mean, as soon as we have the data in a couple of months, we can look at that. Yeah, one last question.
I was going to say, Astrid, I was curious because of the fraction of germline mutations in your lobular registry or family history, because that obviously ties in also with what we might want to look at in wisdom, for instance, right?
Right. So some participants, we made it optional for participants to opt in the HIPAA if they would like to share their genetic testing information. So that's also data to come when we put this on paper, and I can gladly share that with you. But we do have a fraction of participants that mentioned right off the bat during the interview structure qualitatively that they had a pathogenic mutation or that they had family history. And so that's why they were getting screening MRIs before diagnosis as well.
See who you might target with your FAPI PET, for instance, right?
Yeah.
So, okay. Well, thank you so much. Big round of applause. Everyone stay tuned for the schedule of salsa classes that Astrid will be leading. Once a month. And we now have a sponsor for food for dinner for all of them. One of our patients' daughters raised money, and I'm going to use it for dinners to be part of our salsa classes. Not that everyone wouldn't be motivated to come for the dancing, but I know the rest of you will be motivated to come for the food. Okay, right? Okay, Alondra, no, Simona is next. And Simona is going to talk about some other, I think the theme here is, by asking questions of your patients, you can learn more about what's important and really refine your research. So, Simona.
Hello, everyone. Over the past year, I've had the privilege of being involved in two fascinating and important projects, the Cooler Head Scalp Cooling Trial and the Young Women's Registry and Support Group. In pursuit of connecting my involvement in each of these projects, I sought to understand scalp cooling decision-making in young women diagnosed with early-stage breast cancer. As I've continued to work on these projects, my biggest takeaway from working at the BCC has been the value of holistically treating patients, meeting them where they're at, and creating a strong patient-provider relationship. As Astrid thoughtfully and eloquently taught us about patient experiences with lobular breast cancer, I hope to continue adding to our understanding of patient decision-making by switching over to scalp cooling. In order to better understand the scalp cooling decision-making process for young women diagnosed with breast cancer, I utilized the Young Women's Registry developed by Dr. Joe Chen and colleagues at the Breast Care Center. The Young Women's Registry has enrolled all patients at UCSF under the age of 45 diagnosed with early-stage breast cancer. Our database includes information about breast cancer biology, diagnosis, treatment, and outcomes, including scalp cooling. Approximately 12.5% of breast cancer diagnoses in the US are in young women under 45 years old. Studying this population is especially significant due to their unique needs that impact treatment decisions, including impacts on fertility, parenting, career management, body image, and sexual health. Using patient survey responses and medical record data, we conducted a survey sub-study within the registry for patients who are under 45, early stage, and were diagnosed within 6 months of entering the study. We performed several statistical analyses to understand the effect of demographic variables, including income, education, relationship status, and children, on whether each patient chose to receive scalp cooling or not. As secondary measures, we analyzed baseline patient promise data from REDCap survey collection and patient satisfaction at 1-year follow-up. We continue to follow up with these patients at 2, 3, 4, and 5-year follow-ups. Now you may be asking yourself, what is scalp cooling? Chemotherapy is used as part of a cancer treatment plan in order to kill the tumor cells. In this process, however, it can have extremely difficult side effects, including damage to one's hair follicles. Cold caps were developed to decrease blood flow to the scalp during chemotherapy treatment, hoping to prevent the chemotherapy drugs from affecting the hair. The most common scalp cooling systems used at UCSF are Penguin and Dignicap. Breast cancer is a unique diagnosis in that it often affects aspects of a woman's identity closely tied to femininity, including premature menopause, changes to the breasts, and other side effects. Hair loss is no exception. It is deeply connected to many women's sense of self and autonomy. By offering the opportunity to maintain control over one's appearance through scalp cooling, patients may experience a meaningful improvement in body image and quality of life during treatment. Using the Young Women's Registry, I identified 265 patients who were diagnosed with early-stage breast cancer under the age of 45. 202 of these patients received chemotherapy and therefore had the option to pursue scalp cooling. 107 patients, or 53% of these patients, received scalp cooling. The median age of our participants was 38 years old, with most receiving neoadjuvant and non-AC containing chemotherapy. Approximately 2/3 of our patients were married and under 20% were single. We found no difference in relationship status in patients who decided to use scalp cooling versus not. Nearly 90% of our patients were college graduates or had advanced degrees. Here we also found no difference between the use of scalp cooling and patient-reported education level. Over 50% of our patient population had at least one child, and there was no significant association between having children and the decision to use scalp cooling. Patients who received scalp cooling numerically had higher income, with over 75% making over $100,000 a year versus slightly above 60% for those who did not use scalp cooling. However, still, this was not statistically significant, and there was no difference between these two groups. After finding no statistical significance between any of our demographic variables, we began to ask ourselves why. The results on income were particularly challenging our assumptions about scalp cooling decision-making, as many patients pay up to $3,000 out of pocket for treatment. So we explored more into psychosocial factors and patient satisfaction. We analyzed psychosocial measures using promise surveys within the registry to better understand if feelings of anxiety, depression, and cognition and sleep scores were associated with the choice to use scalp cooling. Again, there were no significant associations for any of these promise variables, although all T-scores were consistent with worse symptoms for anxiety, depression, sleep, and cognition, pointing to the emotional distress present during a cancer diagnosis that affects all decision-making. However, our patient surveys at one-year follow-up told a different story. For 35% of patients, they reported using scalp cooling for their children, which includes helping shield them from trauma and the desire to maintain normalcy in family life. This desire for a sense of normalcy and control over one's diagnosis is further reflected in a patient's personal, public, and professional life. The biggest factors for many, however, revolved around the long-term benefits of scalp cooling, helping hair regrow faster and reducing the chance of permanent hair loss. About 57% of patients stated that they used scalp cooling to help regrowth and 62% to prevent permanent hair loss. This points to the value of hair as part of patients' identity, expanding far beyond the duration of cancer treatment, and the value of educating our patients on the long-term effects of chemotherapy-induced alopecia. For those who chose not to use scalp cooling, our one-year follow-up survey asked them why not. During an already emotionally and physically taxing diagnosis and treatment, the costs of scalp cooling, including discomfort, stress, and added treatment time, outweigh the potential benefits for many patients. This further points to the individualistic nature of this choice, as each and every patient may make a different scalp cooling decision based on their own psychological state, feelings of identity tied to their hair, and desire for simplicity and control amid an already complex treatment. With 68% of patients not using scalp cooling because they perceive the hair loss as temporary, we also encounter a vital point to be informing patients about: that some chemotherapies, like Taxotere-containing chemotherapy agents, have a small chance of inducing persistent or permanent hair loss. However, for those who did complete scalp cooling, many found the extra time, stress, and discomfort worth it. 66% of participants were either satisfied or extremely satisfied with the efficacy of scalp cooling, and 80% of participants stated that they would use it again. These outcomes show the value of proper patient education and understanding of scalp cooling in order for each patient to be able to make a decision that aligns best with their identity, body image, and that gives them a sense of control over their own treatment. In analyzing demographic and psychosocial variables and finding no statistically significant findings, we actually learn a lot about medical decision-making. A core part of patient decision-making is feelings of identity and control, especially with a breast cancer diagnosis. The complexity of this decision, along with many others, are much more nuanced than our statistical analyses could quantify. Scalp cooling, being a treatment centered around body image and quality of life, is especially reflective of the nuance of medical decision-making because of its deeply personal nature. In understanding the presence of this nuance, we can see patients holistically and help them make the decision that is best for their mental, emotional, and physical health. However, it is vital to point out that our patient population was primarily composed of patients with high socioeconomic status, reflecting the need to continue expanding this research to better encompass patients across all demographics. In the future, we hope to analyze more aspects that may play a bigger role in scalp cooling decision-making. I plan to increase the sample of patients specifically with PROMIS data while also looking at one-year follow-up PROMIS scores. I also plan to conduct further statistical analyses looking at associations between scalp cooling satisfaction with demographic variables of income and race, how much money was spent out of pocket on scalp cooling, and the amount of hair loss. I hope to submit these further analyses to the San Antonio Breast Cancer Symposium. As I continue to work in the cooler head study, I also hope to continue to gain insight into the patient experience with scalp cooling and give feedback to a new and innovative technology that may make scalp cooling more accessible to all in the future.
Beautifully presented, and just again, I think all the new folks will see the very patient-centered decision-making theme, and not everyone has the same values. And I think I love particularly that the people who picked, it wasn't consonant with their values, and people know what they're getting. I think it's expensive, even if you get financial support, right? So, but maybe not enough for other people. And I love I think that slide you have about, so about a third of people, it's about preserving their privacy or, preserving the look, or masking some of what that is to their kids. But then really, the issue about Taxotere, what would be a better way to solve that problem? Is Taxotere really different from Taxol?
Once I have an MD, I will be able to better answer the question between those two.
It's not different. Okay, if I told you it wasn't different, but it's bad habit because people like to use regimens that are published.
Right.
What would your advice be to oncologists on the basis of this data?
That when discussing treatment plans between different therapies, to also include scalp cooling as part of that discussion, and to include the permanence or possible permanent or persistent hair loss in that discussion from the beginning.
Yeah, and please add to the paper that there really isn't a reason in 2025 to be giving anybody Taxotere. I think we'll see if Joe will be good with that. But I mean, seriously, they're the same. Why are we giving a drug that has a 10 to 20% chance of permanent hair loss? That showed what a big driver that is. I really want you to highlight that. This has been something I've been talking about for a long time. It makes me crazy. Yes, Jeff. Yeah.
Yeah, I was great presentation. I was struck by this 17% said they couldn't afford it. And yeah, that it is just fascinating how,
despite the help that they get,
how much money is spent on healthcare, and yet this is clearly an important issue to people, and they're paying out of pocket. So I just thought it was worth highlighting. I was also struck by the fact that, from my point of view, only 80% said they would do it again. Now, why do I say only? Because there's a lot of evidence in decision science about how cognitive dissonance, like when people have made a decision, and especially if they've invested their own money in the decision, it's very difficult for them to not think they would do it again. Even if they've suffered, like, there's a lot of studies about it that, paradoxically, sometimes even when people suffer more, it's like there's some puritanical like response where they then think, no, I would definitely do this again, right? So I think that's actually worth exploring, like the 20% who didn't want to do it again, like what are we learning from them? Yeah.
Right. Yeah. So I'll touch on the financial aspect first. So this study was the participants started from 2018 up until the present day. And so I believe it was in 2022, Medicare began offering coverage for scalp cooling, but only up to around $1,850. And we have the financial data. I looked at that as well. And I think it was about 40% of patients paid over $1,500 out of pocket for their scalp cooling treatment. That being said, yes, our data is from 2018 until now, so it'd probably be interesting to look at if there's a difference since that was implemented. And yeah, particularly interesting because our population of patients, most of them were of high socioeconomic background. So there is more of a push now to get coverage for this type of treatment, but it's not yet commonplace and standardized amongst all insurance companies. And then for the piece about people who said they wouldn't do it again, there's a lot of variability in outcomes still in scalp cooling treatment. It can depend on hair type. Maybe you dye your hair and have been regularly dyeing your hair for years. And because of that variability, many people do scalp cooling and still lose, 80% of their hair. And so for a lot of those people, we actually have survey data starting from kind of at baseline, how much hair would you lose and think that it's still worth it to do scalp cooling? And then at 1, 2, 3, et cetera, year follow-up, how much hair you actually lost. And so I think that in understanding why people would not do it again, I think that's a really big component, because some people might lose 20% of their hair and find that really psychologically difficult. And some people might lose, 50, 60 and still find it to be worth it. So that's an area that I think would be interesting to look at.
I think there are two things worth looking at. I mean, one is that even when you lose a big chunk of your hair, when your hair starts to come in, by 3 months, you look almost normal. That's so instead of a year, it's like more like 3 months. The second thing that I think is very interesting is that with the advent of coverage, everyone wants their piece of the pie. So who is the other factor that's charging now a lot for scalp cooling?
Well, the insurance companies,
they're reimbursing, but who's charging? Who's now added a big chunk?
Like the actual companies, you mean?
No, not just the companies. Who else's hand is in the pot?
The hospitals.
Yes.
Yeah, the infusion centers.
Oh yeah.
And especially too with DigniCap, you require a medical assistant to be trained to put it on. And with Penguin, you actually have to have someone trained to put it on, which costs extra money to train that person to accompany you at each visit. And so that kind of that added service is where a lot of that extra cost comes from, which is why we have this Cooler Heads trial now, which is a portable and autonomous system, which will help cut that cost down as well.
Yeah, although it may not work as well.
We'll see.
We'll see.
We'll see.
Great,
All right.
great job, Simona. I just wanted to say, great job. I'm on Zoom. I don't know if you can
Thank you, Dr. Chen. Thank
but
you.
I think that, as you said, and it's a great point, that our patient population is not typical. This is, unfortunately not generalizable because of the high socioeconomic status. I mean, 80%, I think even over 80% of our patients have, a college or advanced degree, and 75% made over $100,000 a year. I think about over half made over $200,000 a year. So that's why perhaps we are not seeing that cost is an issue, or not different between those who use scalp cooling versus not. One of the things that Simona is going to work on is looking at how much patients spent and how that is associated with their desire, or whether they would do it again, and how the Pama scores measure at 1 year to see if expense has an effect. Because we're not seeing a difference between the two groups, but I think that's just because everyone had a high income.
Yeah, but I also, Joe, I would love to see you guys chart how the costs have changed since we started this, because the hospitals have now added a charge, and they're doing that everywhere, which is just super irritating. But I mean, that's really going to make it affordable. I mean, the last things I saw were just ridiculous. So, I mean, it's true, it is an expense, but I think we have to really think hard about it. Little public shaming goes a long way. So more fun and games. Okay, big hand for Simona and Joe. Okay, there's one more presentation between us and lunch. Okay, Alondra, take it home.
Hi everyone, good afternoon. I'm Alondra, and start off with my most important lesson that I've learned at the BCC is the importance of practice-based learning. I feel like it applies to many different areas in what we're trying to grow in as BCC interns, whether that's observing appointments and learning from patients, learning from our mentors and our doctors, learning from ourselves and what works well for us. And yeah, so I am going to talk to you all today about patient education implementation at the BCC. And I'm going into this taking for granted that you guys are all aware of the fact of the importance of patient education on outcomes and informed decisions. So what I'm really trying to do here is highlight the implementation of patient education. So first, start off with a story from a patient that I had a scribing appointment a couple months ago. She came in confused and frustrated from a complication from a surgery. She said, "It's impossible for me that I'm learning more on Facebook than from the doctors. I feel like UCSF must have this information, yet it's not being disclosed." And this isn't a blaming or shaming game. This is to highlight an all too common experience of missing but knowable information. So the problem isn't the lack of information, the problem isn't that there's a lack of information. There's often too much information. The real challenge is how do we make sure that patients get the right information at the right time? And I believe that answer falls into implementation, which is a common theme today. Thank you, Marcello, for really honing that in for us. So at the BCC, we have the tools. We have Autonomy, which is a video-based patient education vendor. We have the BCC website, which is the library of written materials, and then we have other resources. And there's a bunch of other educational efforts going on as well. So the issue isn't the content, it's the structure. What we need is an organized system that ensures that the right content reaches the right patients at the right moment in their care journey. And yeah, also remember Dr. Esserman saying something that really resonated with me. You can have a great idea, but if you don't have a good implementation strategy, then what's the point? Which I find to be very true in kind of what I'm trying to highlight here. And the challenge here isn't educational, it's operational. Great content must be supported by strong systems in order to have an impact. So if the issue is the structure, what does the structure actually look like? And I like to frame that around Don Kemper's model of information therapy. So starting off kind of with the first layer, the right information or the educational platform layer, seeing it or in the perspective of patients are often bombarded with conflicting information. How do we ensure that information is accurate and consistent? The right person or the organizational layer with limited funding and scattered priorities, how do we make sure that we sustain and maintain the work institutionally and at the right time, or the patient layer? So how do we integrate everything and all the resources that we have into the patient journey so it shows up when it needs to show up, not when it's super overwhelming? And at the BCC, we are very fortunate to have a lot of strengths when it comes to implementing, whether it's patient education or just in general, expertise, cutting edge work, culture committed of personalized and patient-centered care. And we also have our PSC intern workforce, where if anyone doesn't know what PSC is, it's Patient Support Corps. And we are patient advocates and join patients along their appointment or help create a list of questions before their appointment to help prepare them for their appointment. So we are really at this golden opportunity where we're able to deliver information or education to patients before their appointment. So the issue is, or there's currently no centralized approach for managing patient education at the BCC. The education efforts are happening, but they're scattered across clinics, websites, platforms, different materials. Without a system to connect and maintain these efforts, we risk missing the mark, delivering education too late or in the wrong format or not at all, similar to the patient story that I shared at the beginning. So how do we implement and sustain patient education at the BCC? What are the barriers? My goal here isn't just to show you what's missing or what are the barriers I experienced in kind of my journey into this implementation, but to also spark a conversation so we could figure out solutions of how we could figure this out together. So mitonomy, like I mentioned, one of the educational platforms or resources that we have at UCSF, first entered UCSF at 2023, and about a year ago, we started working with them and learned amazing things about mitonomy, such as the integration with MyChart. You could track who's watched it and who's viewed the content, which is really helpful for consistency and accountability. But in November, we reviewed some of these videos during our faculty meeting, and it was not the biggest hit. The videos simply put didn't meet the BCC standards. So while the structure of mitonomy works, really highlighting the MyChart integration and the way you could track views and availability in multiple languages, the content didn't match our clinical standards. So we have a good structure, now it's a content. And what about the structure if we're changing the content? So we discussed with mitonomy about what are our options to customize the content or create new content. And we started off with a solid plan, but ran into some barriers in terms of being able to customize or create content, such as limitations from UCSF and the patient in the patient education department in terms of the customization credits. We have our providers. There was 2 providers who volunteered to share feedback who weren't at capacity to follow through with the feedback and signing contract and just a little bit of these things where we know we have a good structure, now we're changing the content and running into barriers to changing the content. So what I'm trying to get at is how do we create a reliable structure to manage this long term? Mitonomy isn't able to necessarily, based on my experiences, assist with that. So what about the BCC website? Why not just send patients to the BCC website? And actually, I thought about this a little bit more and I tried to look at it from the patient perspective and starting off with a common question of what are my treatment options for DCIS? So kind of just going through Google and seeing what came up, what UCSF resources came up. And kind of the main takeaways that I have is that the content is great. Really amazing content, and I feel like I learned a lot while I was searching through this content. But the issue I ran into is the navigation and inconsistency in terms of the different websites available. So have a main centralized website where you could find this information in a reliable manner is kind of what's missing. This is, for example, on one of the last websites where nothing really came up. So yeah, the BCC website, comprehensive and informative, clearly written and easy to understand, wide variety of resources, but minimal personalization, missing that accountability like mitonomy has that capability through Epic. And with the website, the content is only available in English, mainly the educational content. There are resources in languages other than English, but I did have a little bit of trouble finding those when I was initially doing my search. So this really comes down to a buy versus build. We have this existing structure, mitonomy, but running into barriers with using that structure. And then we have this build option where we have great content, great opportunity for patients to learn comprehensive information at UCSF, but there's no centralized structure. There's a bunch of different educational efforts. I know all of you guys are also in your own projects, working on your own pamphlets for your own trials. And how do we make sure that this content is available for all the patients? So my call to action to all you guys is, I know I asked you guys a lot of questions today. I know I'm typically telling you guys the answer to these questions, but I really wanted to highlight these barriers and so you guys could think about these questions. And tomorrow at Sparking Innovation, we're going to be talking about solutions to address these questions and this issue I'm highlighting. So please come to our breakout session. And thank you to my fellow interns, Francesca, Jeff, Laura, for all your guidance and mentorship, and to the patients and families who really guide and inspire this work.
I don't know, is Sarah here or are you online, Sarah? No, so this is actually something like trying to remember, must be 4 interns ago, that we decided that like there are all these different websites. There's the surgery website, which in fact for breast should just, I mean, everybody, even at a big institution like UCSF, they want to have their own thing and the Cancer Center want to have its own thing. So like if we build the content, you need to refer to one place. And we got this commitment to build our website as the central place. And instead of building all these other ones in addition, that they were supposed to just direct to that if you clicked on it. And somehow that seems that we had that for maybe 1.5 years and somehow it's all fallen off. But we have to, but again, if we want to do this, we have to like make a commitment again to all these people. And who's assigned the website this year? One of you is assigned the website. Why is nobody raising their hand? Okay. Oh, I'm going to do some drafting. There's
the implementation challenge.
There's the implementation challenge. But I'm going to get at least 4 of you. And Kenny, since you know the clinic so well, you're sadly going to have to get involved in some of it. But I think that I think this is a solvable problem. It's a solvable problem. And we're going to start solving it when? Tomorrow. Right. Yes. Okay. Any burning questions, please come tomorrow and help us solve this problem. I mean, again, if we're bothering to do all this work, why do it? And why have all these brochures and all these things? Our content is really good. If we don't make it available, what's the point of having it, right? Okay. So you're right. Dedicated team, which is about implementation. Okay, everyone's got that drilled in theirs. Okay. If there are no burning questions, let's all go to SF Kebab. It's just across the street, and we're going to start promptly at 1:20 for the afternoon sessions. Okay.
Awesome.
Back to, I think you're here. Yeah.
Correct slide. Now we're good.
Can everyone online see the slides?
Yes.
Okay, great. Okay, so this afternoon we're continuing with more amazing intern presentations, and we are moving into, we're continuing our talk about the additional things that we do to improve people's quality of life, and one of those is breast reconstruction. Breast reconstruction, however, has its complications. And so to tell us today about a really exciting project to try and think about how we can minimize complications is Michael Choi, and he's going to talk to us about antibiotics, the microbiome, and infections in implant breast reconstruction.
Hi, everybody. Nice to see everybody come back from lunch. Hope everybody has a full belly. The little slump, it's okay. We'll work through it. I promise. I'll try to make this talk as engaging as possible. Okay. All right. Hopefully everybody on Zoom can still see that fine. All right. So hi, everybody. My name is Michael, and it's a pleasure to be presenting our continued work into the relationship between antibiotics and the microbiome in the setting of mastectomy, followed by implant-based breast reconstruction. So before I go any further, I do want to talk a little bit more about the most important thing I learned this year, of course, Laura, which was to look at everything through three lenses: appreciation for what it is, criticism for what it isn't, and optimism for what it can and should be. I think this is something that's been key to a lot of the projects I've been on this past year, and something that will be overhanging for this next year through all the future projects I hope to implement. All right, so as a little bit of background, on average, 1 in 8 women will develop breast cancer in their lifetime. And of those diagnosed, 40% will undergo a mastectomy. Additionally, 1 in 400 women will carry a germline mutation, BRCA1 or 2, not to mention plenty of other germline mutations that exist, influencing many more to undergo a prophylactic mastectomy in response to heightened risk for breast cancer. Breast reconstruction has been demonstrated to have positive effects on adjustment to life after cancer diagnosis and treatment, self-image, and return to normal daily activities. In 2023 alone, over 150,000 breast reconstructive procedures were performed in the US, a 4% increase from the year prior, and we expect this number to increase in the coming years. Of the two main methods of breast reconstruction, that being implant-based and autologous reconstruction, the former is generally considered more common. This can be contributed to factors such as shorter operative time, faster recovery, and no donor site morbidity. Two routes can be taken for implant-based breast reconstruction, either a single-stage direct-to-permanent implant or a two-stage tissue expander reconstruction, followed by exchange for a permanent implant. However, the largest con and risk is of infection. Infection rates historically average around 15 to 20% and up to 30% for those who receive radiation. This can lead to delays in post-operative cancer treatment and in severe cases require readmission and reoperation. Current research is pointing to the microbiome as a novel and possibly modifiable risk factor for the development of implant infections. The microbiome is a term used to describe the collection of different microorganisms that live within us and their relationship to our body. Everybody's microbiome is unique, and each region of the body can host entirely vastly different bacteria, from the skin to the gut to the breast. And years of prior research has highlighted the influence of the microbiome when it comes to susceptibility to infections and disease, including cancer. And one agent that we know that will certainly affect the microbiome are antibiotics. While antibiotics play crucial roles in treatment and prevention of surgical site infections, we of course have to consider all of the adverse effects that come with prolonged antibiotic use, including disruption of the microbiome, which can instigate colonization of antibiotic-resistant bacteria and subsequent infections. In the context of implant-based breast reconstruction, several studies have compared antibiotic prophylaxis duration and shown equivalent efficacy in preventing infection. However, this has not yet led to universal adoption of shorter courses of antibiotics. Additionally, no studies have shown what effects antibiotic duration may have on the breast or the gut microbiome, nor have any studies shown how the microbiome may change pre versus post-operatively. Therefore, we set off to answer the question of how might the microbiome and perturbation thereof relate to outcomes of mastectomy with implant-based breast reconstruction? To answer this question, we designed a randomized clinical trial recruiting women planning to undergo a mastectomy with immediate implant-based breast reconstruction. Patients were randomized to one of two arms to receive either 24 hours of antibiotics or 7 days worth of antibiotics post-operatively. 4 sample types were collected: a pre and post-operative stool sample, a skin swab immediately before surgery, a tissue sample intraoperatively, and periprosthetic fluid during each of their post-operative clinic visits. All right, so let's start off by looking at broad infectious outcomes. So a total of 116 patients, or 202 breasts, were included in this analysis with at least 3 months of follow-up. The cohorts showed no significant difference in demographics with the exception of BMI, which will be a focus of later analyses. And additionally, these cohorts showed no significant difference in rates of infection, nor time to infection, nor rates of explant, nor severity of the infection itself. Next, let's take a look at the microbiome diversity. So for the sake of time, I'm going to focus solely on just the stool samples that we've submitted thus far. Stool samples from the first 39 patients were submitted for sequencing, 16 srRNA sequencing. Recounts were used to determine the abundance of different genera present in these samples, and the Shannon diversity, a measure of both species richness and evenness in a sample, was calculated. Both cohorts showed a significant difference in diversity scores pre versus post-operatively. However, the 7-day cohort, as you can see on your right, showed a much more significant decrease in biodiversity. I'd now like to walk everybody through just a couple of examples. So first, we have patient number 11. This patient was on 24 hours of antibiotics and healed without complication. We can see that the microbial diversity remains relatively unchanged between pre-op on the top and post-op on the bottom. You'll notice for the next couple of samples, Bacteroides and Faecalibacterium, Bacteroides in red and Faecalibacterium in orange, remain prominent genera, aligning with previous research. Next, we have patient number 3. This patient was on 7 days of antibiotics and also healed without complications. Overall, we do see a general decrease in the abundance of the top 10 genera of bacteria, but nothing drastic. Now we have patient number 21. This patient received 24 hours worth of antibiotics, and she developed a late indolent infection more than 2 months after surgery, prompting an exchange from tissue expander for a permanent implant. Here you can see a much more dramatic shift in her microbiome pre versus post-operatively. Pre-operatively, her stool's microbiome was composed of nearly 50% Bacteroides in red. However, post-operatively, her stool's biodiversity is completely changed post-operatively with a large increase in Allocytes in purple. Interestingly, cultures of her infected tissue expander came back positive for Staphylococcus, which is inferred to interact with Allocytes in a priority effect, which I'm happy to talk about later on. And lastly, we have patient number 29. She was on 7 days of antibiotics, and unfortunately, she developed an infection almost a month after, and this required explantation of the implant. Here, we do see general decreases in species evenness generally across the board. However, what is of special interest here is the increase in the uncultured genera, which is in like that salmon light pink. And this is warranting further investigation and reevaluation of our currently used reference genome database. All right, in conclusion, with these preliminary results, we find that modification of antibiotic duration presents a really new strategy for intervention in patients undergoing breast reconstruction to improve broad surgical outcomes. And while both of our cohorts encountered similar rates of infections and impacts to their gut microbiome, we see that the 7-day cohort suffered a much more significant decrease in their gut microbiome biodiversity. As for study enrollment, we have currently enrolled 160 patients out of our goal cohort of 200 patients. And as such, for future steps, of course, we will continue sequencing these samples for the additional 100+ patients that have been in our trial to add to these current results. And we also plan to perform additional sub-analyses for groups of interest, including patients who do and do not develop infections and different severities of infections, those with histories of neoadjuvant chemo and different lines of chemo and radiation, and also patients of different BMI ranges. All right, thank you, everybody. Quick thank you, of course, to Laura, Francesca, everybody here, my mentor, Dr. Piper. Yeah, thanks.
Okay. Yeah. Right there.
All right, thanks. I look through these things, from the decision-making perspective. So as a patient, am I right in thinking that the adverse effect to the gut microbiome, is that pretty reversible? Like if I then after 7, so because what I'm really thinking as a patient is I do not want an explantation. I don't want an infection that's going to affect all the surgery that I just had, everything. So maybe I tolerate 7 days of antibiotics and then, eat a bunch of fiber and yogurt and whatever afterwards. How reversible is this?
That's a great question. That's not a current focus of this study, but I definitely agree with you that there are current interventions available to help dampen the effects of antibiotics. In many cases, and is the standard of care here at the BCC, for those who do develop an implant infection and have to go on oral antibiotics, we do sometimes also recommend they take probiotics like lactobacillus in conjunction with the antibiotics to minimize all of the adverse effects of antibiotics, including, subsequent infections and also other things like thrush.
Yeah, I just think this is a risk attitude.
Actually, but there is data from MD Anderson showing that, probiotics do nothing. In fact, they make things worse. And actually, the antibiotic changes can, from a different perspective, change your immunity. And a lot of these patients, especially people with triple negative breast cancer, whatever, that's one of the things we want. So I think it should be back to first principles. First, do no harm. Antibiotics, again, you're going to look at the analysis with how many people got a rash, how many people got diarrhea, how many people got this. If it's not helping you, why in the world are we doing it anyway? Right? Precautionary principle, right?
Exactly.
So much to do. Last question.
This is from Zoom. Okay, this is a question from Dr. Mukhtar on Zoom. She said, great job, Michael. How can you distinguish between cause and effect? Instead of microbiome change leading to infection, what if infection leads to microbiome change?
That is a great question. I mean, I guess you have to consider the overall principle of an infection forming, which is going to require colonization of a certain bacteria, and that will take time. I mean, we have several cases that do develop an infection within the week.
Charger thing too on your desk? No, the little round thing. Oh, right there.
If you're on Zoom, please mute. But I think the other thing that we want to look at is salvage, right? So the thing is, if you develop an infection in the face of antibiotics, what's the chance of salvage? It's got to be less if you're on an antibiotic because there'll be resistance. So that's one of the things you guys got to look at, right?
Of course, yeah. And of course, we'll compare rates of patients who do have to get who can have the implant salvage versus having to get it explanted.
That's going to be the most informative endpoint, right? Right. So why do it? I mean, this is another 15-year project, but Michael, I know you're going to bring it home this year. It's awesome. Okay. Next, our amazing recast program. And to tell you all about that is Lorraine Jiang.
Alrighty. Hello, everyone. My name is Lorraine, and I have been working on the recast trial at the BCC this year. One key takeaway from the BCC internship is that growth does not happen in isolation. I have learned that seeking out the right resources and not being afraid to ask for guidance are essential to becoming a more competent and compassionate member of the care team. And just like how the microbiome is unique to every individual from Michael's presentation, in recast, we're trying to find a individualized approach to patients who have been diagnosed with DCIS. And I want to begin this presentation by sharing 3 key takeaway points. So patients who join the recast trial are trying to find non-invasive treatment options for DCIS, and they also want to advance scientific development. And most patients felt that their understanding of DCIS and active surveillance as a treatment option improved through joining the trial. And although financial concerns and appointment scheduling were the main obstacles, every patient did decide that they will recommend this trial to other participants. So let's start off with some background. You might be wondering, what is the recast trial? Well, recast stands for Reevaluating Conditions for Active Surveillance Suitability as Treatment for DCIS. Ductal carcinoma in situ, or DCIS, is a condition where cancer cells are still confined to the breast duct and not yet progressed to invasive breast cancer. Currently, the standard of care is surgery, either breast conservation and radiation or mastectomy. However, there is no compelling evidence or data to show that surgical removal as the first intervention is the best and only option for all patients. In fact, data from the COMET study showed that active surveillance it's a safe alternative for initial treatment for hormone receptor positive DCIS. So the recast trial aims to identify candidates for risk reduction versus focal surgical removal by reordering treatment, starting with neoadjuvant endocrine therapy, followed by serial imaging to assess individuals' treatment response. Currently, we have 15 sites that are open and activated in the US, and we're aiming to open a couple of other sites to reach our goal of 30 sites in this year. In terms of progress update, there are 45 patients who have signed the consent, 9 are in screening, and 31 have started treatment. And this trial opened in January 2024. So while I was working on this trial with patients and talking to potential patients, I realized that I'm very curious to find out the main reasons for patients to join a clinical trial like this rather than standard of care, and how can we as the care team to improve their experience while on trial. So here are some of my project goals. So I wanted to gather and document the main reasons that patients choose to join recast. I also wanted to identify the main challenges for joining the trial. And I also wanted to record how the patient's understanding and perspective on DCIS and clinical research have been influenced by the trial. So to accomplish this, I created a patient-facing trial experience survey, which was sent to be approved by the IRB and then sent to all UCSF recast patients via DocuSign Part 11 or in person with the consent form attached. And here are some of our question types. So as an example of a multiple choice question, we asked what were the primary factors that influenced your decision to enroll in the recast DCIS trial, and we provided the patient with some options and with the others option as well, so the patients can also put in their own thoughts if it's not listed already. And for the ranking question types, we ask questions like, before or after joining the clinical trial, how well did you feel you understood the differences between the trial and the standard surgical treatment on a scale of 1 to 5, with 1 being not at all and 5 being very well. And we also included open-ended questions such as, would you recommend participation in a trial like this to other patients diagnosed with DCIS? Why or why not? So within the UCSF recast cohort, we actually were able to get 80% of our patients to participate and complete this survey. And with 2 patients declined due to technical difficulties while they're traveling abroad, and 2 patients declined due to personal reasons. And the majority of patients who finished this survey or so the majority of patients completed the survey via DocuSign Part 11. So to answer the questions of why patients decide to join the trial, I found that the top answers include there is a strong interest in finding non-invasive treatment options, and the patients also really wanted to avoid surgery and the subsequent radiation. Patients were also very motivated to advance scientific development for other patients in the future. And patients also mentioned that there is this trust in the research and care team here at UCSF. And here are some patients' testimonies. So one patient mentioned that joining the trial made her become more hopeful for a non-surgical, non-invasive treatment option for her and other DCIS patients. And this other patient mentioned that joining this trial has opened her eyes to a more personalized course of treatment than the standard of care. And in terms of patients' understanding of DCIS and active surveillance as a treatment option, on a scale of 1 to 5, with 1 being not at all and 5 being very much, there's an overall increase from 3 to 4.87 of their idea about DCIS and recast as a treatment option. And we also found that 75% of patients mentioned that they had minimal side effects and felt that their current treatment was better than the standard plan proposed to them at first. And like I mentioned before, all patients would want to recommend this trial as an alternative to avoid surgery to other patients. And now let's move on to how we can improve their experience while on trial. So one of the most mentioned obstacles, I think also echoing to what Simona has mentioned in her presentation, is financial concerns. So there are really some challenges with finding a referral and insurance cover plan, especially for patients who are outside of the UCSF care facility. And sometimes it takes more than 2 weeks for them to simply obtain a referral first. And patients also mentioned that the time that they took to travel to the clinic can be troublesome for them because of traffic and commute hours. And in fact, I think 25% of our patients here are actually living out of state. So that means they have to take hour-long flights to fly into San Francisco for every appointment. Another common theme that patients mentioned is trial design. So one thing is that some patients highlighted it could be a bit confusing to read the MRI imaging report, which in response to that, we also developed the RR that Marcello mentioned first for ISPY. So we also implement that in recast. Some patients also highlighted that they would really want to have more accessible information even before joining the trial. So I partnered with Sam and Dr. Jackson to create this new brochure that has a step-by-step link to what to expect if you're interested in joining the recast trial, and to give the patients a general big picture of what to expect. Other patients also highlighted that because we currently use a paper form of pill diary, it can be a bit troublesome to keep track and to always bring it with them. So we're thinking about moving that to an online platform that is soon to come in this year. And so why this test is important to me. So by doing the survey, I could actually understand patients' motivations for choosing active surveillance. It also helps me to understand how patients process risk, information about DCIS, and recommendations from physicians. It also pinpoints factors that may discourage participation and also empowers patients by valuing their perspectives and experiences. This task also informs how we consult patients in the future, which could possibly lead to workflow improvements. And here is just another testimony from one of my patients. She's super grateful for Dr. Esserman and the entire team here at the Breast Care Center to help her through this trial and this entire treatment journey. So just to wrap up, the three key takeaway points is that patients join the recast trial really to find non-invasive options for DCIS and to push forward scientific development for other patients in the future. And most patients felt that through joining the trial, they understood better of their condition and active surveillance as a treatment option. And we found that financial concerns and scheduling were the main obstacles, but patients will still strongly recommend this trial to other patients in the future. And I just want to wrap up by saying thank you to all my mentors, Laura, Heather, Jennifer, Kelly, Dr. Jackson, Christian, and Francesca, and of course, all my amazing BCC interns for helping me throughout this year. Thank you, guys.
Great job. As I said to Jeff just now, we are succeeding in our training about shared decision-making. Okay, so awesome. Questions for Lorraine from the group? Okay, I will ask one for you. What's the one thing from your interviews that you can take away that would make you want to do something different?
I think not only just from the interviews, but from talking to prospective patients and patients on trial, I think there is so much as a CRC and as part of the clinical care team for us to really step out of our comfort zone and to really think from the patient's perspective in terms of how we can streamline workflow to minimize their obstacles in obtaining care and more accessible information. Because I think there's just so much information out there that sometimes it's a bit overwhelming for patients to kind of absorb and understand in a very stressful and short period of time. So I think just from talking to patients and also hearing their feedback after they've joined the trial really made me want to push forward this process.
Yeah. Just like with ISPY, getting that brochure that's integrated into the care process. This is what you might normally be asked, but here's a clinical trial option. So having those as standard, where's Alondra? You know, there's no reason we have these. They're just not in the right place, but we can do it. We've already done it. And I have to say, I challenged Lorraine to figure out how to get everything done in one afternoon for a patient who lived 2 hours away. Although she was dubious, she was very successful and changed it for everybody going after. Okay, fantastic. Round of applause. And while we're talking about DCIS, then there's the DCIS that we can manage with hormone therapy that probably don't, where the vast majority probably don't need surgery. Then there are the more aggressive ones that we really worry are more at risk to develop hormone negative or HER2 positive cancers. Is there a solution for them? Okay, Choi, come tell us about it.
Hi, everyone. I'm Chaylee, and a meaningful lesson that I learned this year at the BCC is that resilience through challenges provides an excellent opportunity to rethink what we can do better and to grow. And so, as Laura mentioned, Lorraine's presentation on the RECAST study, which explored endocrine therapy, I will be presenting on a study that also has a similar goal of learning which patients can successfully avoid surgery. And this is by using an intratumoral immunotherapy injection for high-risk DCIS. So as Lorraine mentioned, DCIS is a precancerous condition where cancer cells grow inside the duct but are still confined to the walls of the duct. And some patients with DCIS can progress to invasive cancer where cancer cells spread out of the duct. So this is an example of an H&E stain of a patient. The DCIS you can see on the left side there with the cancer cells confined in the duct, and in the invasive it has come out of those confines. And so why are we interested in using immunotherapy in this DCIS setting? Previously in the I-SPY 2 trial, the addition of pembrolizumab to standard neoadjuvant chemotherapy more than doubled the pathologic complete response rates compared with chemotherapy alone for both hormone receptor positive, HER2 negative, and triple negative breast cancer. So as an invasive disease, neoadjuvant immunotherapy could potentially help with the progression of DCIS. And since the mortality threat of DCIS may not justify toxic chemotherapy or intravenous immunotherapy, that could cause systemic immune toxicity, it would be very interesting to use it in the DCIS setting. And also localized intratumoral injections of the immunotherapy is all the more appealing because the localized approach allows a smaller dose and then also reduction of risk of the systemic immune responses. Another finding from our group showed that proximity of T cells to tumor cells in DCIS predicts a lower risk of development of invasive ductal carcinoma. So in immunotherapy treatment, one of the goals would be to bring T cells and other immune cells into the area of the DCIS lesion. So that led to a previous cohort of patients that received an intratumoral injection of pembrolizumab. And this cohort demonstrated the feasibility and safety of such intratumoral injection of immunotherapy. And so in this cohort, we observed increased T cell infiltrates in 7 of 9 DCIS lesions, but not regression. So this type of therapy successfully brought immune cells to the region, but for some reason, they weren't being activated to get rid of the DCIS. So that led to an addition of an mRNA triplet drug called mRNA-2752, which is a lipid nanoparticle encapsulating mRNA containing 3 immunomodulatory proteins, OX40 ligand, interleukin-23, and interleukin-36 gamma. So the point of this addition was to hopefully activate these immune cells that are brought into the region by the pembrolizumab. So in this study, women with biopsy-proven high-risk DCIS were enrolled, and they had to meet any of these 2 following categories, 2 or more of these categories of age less than 45 years, high-grade DCIS, palpable mass, size greater than 5 centimeters, HER2 positive or hormone receptor negative, and they received a baseline MRI and a core biopsy. And then they received the intratumoral injections, 2 to 4 doses and 2 to 3 weeks apart. 10 patients received pembrolizumab plus the mRNA triplet drug, and 11 patients received the mRNA only. And following immunotherapy, they had a repeat MRI and tissue removed either surgically or biopsy through surgery or biopsy, and this tissue removed before immunotherapy and after immunotherapy were used for multiplex immunofluorescent staining. And so this is an example of MRIs from the dual therapy, which was the combination of the pembrolizumab and the mRNA drug. So at the top, you can see an example of a complete responder. The lesion at the beginning, the yellow arrow is pointing at it. You can see that enhanced area there. And then following immunotherapy, that enhancement has totally gone away. So that's an example of a complete responder. And at the bottom is a partial responder. You can see the lesion decreasing over time, but it's still there. So this is a summary of all 21 patients' response by MRI. So here is graphed each patient's FTV change, comparing their initial MRI to their final MRI and seeing the difference in tumor volume there. So basically everyone on the left side had a complete response with their lesions going away. And then on this right side above the 0 line would be people whose DCIS lesions increased in size. And another note is people in the dual therapy cohort are in dark blue and the light blue is the monotherapy. So overall, 6 patients had a complete response. 2 had a partial response, meaning they had a greater than 30% decrease in their FTV, but not a pathologic complete response. 6 stable disease between those 2 dotted lines of 30% decrease or 20% increase. And then 7 patients, their lesions grew above 20%. So in the following analysis I'll be sharing, we'll group the complete and partial responders together into objective responders, and then the stable disease and progressive disease together into non-responders. So as you can see from the previous slide, there were many patients who responded well, but many patients who didn't also. So we wanted to look at the biological differences between these responders and non-responders. And we did this by looking at the immune cells in the tumor microenvironment through multiplex immunofluorescent staining, as I mentioned before. And another note is that these immunological results that I'll be speaking about focus on the pre-treatment core biopsy. And so this image here is an example of the multiplex immunofluorescent staining. They're both pre-treatment biopsies. There's one case on the left side with low tumor infiltration. Yellow stands for cytokeratin, the tumor cells, green CD3 positive T cells, and pink CD20 positive B cells. You can see there's not really many immune cells there. And on the right side is an example of a case with high tumor infiltration by lymphocytes. You can see kind of those swarms of immune cells there. So one of the analysis that we completed was looking at the percentage of a given cell type. Sorry, the color didn't show up for this for some reason as we were sending all our slides. But basically, we looked at the percentages of 26 different cell types. So for an example would be B cells. So the percentage of B cells over the total cells that are in the area, including B cells, tumor cells, macrophages, T cells, etc. And so after running this analysis on 26 different cell types, we found 3 significant results, which are blown up here. So we saw that a higher percentage of B cells pre-treatment did correspond with better response. So people who had a higher percentage of B cells actually responded more frequently. And then also HLA-DR positive B cells, which are activated B cells, and then also PD-L1 positive tumor cells as well. A higher percentage of these cells were in responders. And this last finding is super interesting since pembrolizumab inhibits the PD-1, PD-L1 interaction. So there could be something going on there. Another analysis looked at the distance between cell types to see if certain cell types being closer together is important for a good response. And we did this through a nearest neighbor analysis, which provides a quantitative measure of tumor immune or immune cell proximity. So this diagram shows when the cell types such as tumor and immune cells have longer distances between each other, this results in a lower proximity score. And then if there are smaller distances, the cells being closer together, there would be a high proximity score. So we ran this analysis on 56 different cell pairs. And then again, the 2 significant results are blown up here. So it was shown that responders had a closer proximity between PD-1 positive CD8 negative T cells and PD-1 positive cytotoxic T cells, and also between PD-1 positive T cells and any PD-L1 positive cell. So again, super interesting since pembrolizumab blocks the PD-1, PD-L1 interaction. So overall, to summarize, the intratumoral immunotherapy in DCIS resulted in 8 objective responses and 13 non-responses. And of the 8 objective responses, 6 were from the combination cohort and 2 were from just the mRNA alone. And responders had a higher percentage of PD-L1 positive tumor cells and a higher proximity score for PD-1 positive T cells with any PD-L1 positive cell, which may be why the cohort that received pembrolizumab did better. And responders had a higher percentage of B cells and activated HLA-DR positive B cells. And for future analyses, we will be completing additional spatial metrics, some of which are already done, but we didn't have time to talk about, such as spatial heterogeneity and Morishita horn. Also, we have done autoantibody profiling in serum as well. And then pending are CyTOF and blood samples, cytokine and chemokine assays on serum samples, and spatial transcriptomics. And we're continuing to investigate new drug candidates for this type of intratumoral immunotherapy injection. Thank you so much to especially Mike, Laura, Team at Davis, soon to be UCSF, Sandy, Hide, and Jane.
Hey, proof positive. We're going to make it work. And next week, we're going to find our next new agent, right? Maybe, yes. Hope springs eternal. But see, CyTOF, you got it. We got to figure out how to simplify things so we can learn these things. And we're going to talk to Matt next week too. Okay. One quick question. Now we have time for one quick question. Any? Overwhelmingly positive. Otherwise, who wouldn't want a vaccine for breast cancer? This may be the first example of a phase 1 trial in situ cancer that moves to phase 2/3 in ISPY. That could be very cool. Okay. Thank you. Right. Now, Nandini, you're going to take us on to the wisdom study. Come on up.
Hi, everyone. My name is Nandini, and I have been working on the wisdom study for the last year. And one thing that I've learned from this internship is that medicine and care is so much more than just treatment and goes back a step into prevention. And that's what the wisdom study is so focused on. But my specific presentation looks at the different lifestyle and reproductive decisions made by people on the wisdom study that are diagnosed as high-risk mutation positive. So for some context, who gets breast cancer? Of course, it's dependent on your risk. There are several different risk factors that we are aware of for breast cancer, such as family history, breast density, age, lifestyle factors, race and ethnicity, and so on. But currently, we have one sort of screening regimen that we give to anyone with breast tissue. So the goal of the wisdom study is to look at a novel way to approach screening, which is a lot more personalized. So in this case, we look at annual mammography, which is the current standard, and we compare it to a personalized approach to screening to see if this would overall improve outcomes of participants in our study. So after participants consent, they are placed in one of these two groups. In Wisdom 1.0, this was through randomization, but in Wisdom 2.0, which started about a year ago, participants can now choose whether they want to be in the annual screening group or in the personalized screening. As part of the personalized screening, something that we look at is genetic testing. We provide all of our participants with cost-free genetic testing, which is really wonderful. And we essentially look at 3 different categories of genes. These include hereditary cancers, familial cancers, and more sporadic cancer mutations. This used to be a 9-gene panel, but now with Wisdom 2.0 is a 29-gene panel, which looks at breast cancer as well as other cancer susceptibility genes. Beyond genetic screening, we also look at breast density through the mammogram, and we also collect information from people via their health questionnaires to get some more information about their family history and other lifestyle factors. And we give them a screening recommendation, which can range from 6 months, 1 year to 2 years, or no screen until you're 50. So part of our participant population are these people that are in the 6-month screening time point. These are considered our higher risk population, and they have a breast health specialist consultation after getting their genetic testing, and they are given a 6-month screening assignment. So looking at Wisdom 1.0 data of people that have these high penetrance mutations, we have about 700 participants that fall under this category. And now with Wisdom 2.0, which has opened to participants that are between the ages of 30 and 39, we have 37 participants with the above mutations that put them in the 6-month screening category. So when I was looking at all of this information working as a wisdom study coordinator, I was kind of thinking about what do the participants do next? We give them these recommendations and we tell them what to do, and they have these consultations, but are they doing anything with this information? Are they talking to their provider about it? Are they making changes in their lifestyle? How does, now that we have younger participants in our study who are getting diagnosed with BRCA mutations and other highly penetrant mutations, does this impact their family planning and other things in their life that we aren't really thinking about? So we decided to create a survey to answer some of these questions. So initially this began with a literature search where we scanned the entire internet to find a pre-existing questionnaire that looked at all of the different categories that we wanted to look at. But we couldn't find something that uniquely captured everything that we wanted to ask our participants about. So then began a very long collaborative effort with everyone on the Wisdom team and beyond to help develop questionnaires and emails. So I worked with CRCs and geneticists on the Wisdom team to develop the questions, and I worked very closely with staff to develop some of the emails and the verbiage of these questions to make it a little bit more digestible for our population. And then it was sent over to IRB approval. So for some background information on what these questions are, so there's about three sections to the questionnaire. The first is a little bit more about background information. So which mutation do they have? How did they find out? Have they had a breast health consultation? Have they told their provider about it? Have they told anyone else in their family? Certain more demographic information. The next bit of the survey was more lifestyle changes. Have they made any changes to their exercise patterns, alcohol intake, et cetera? Because these are things that we talk about in the breast health consultation with our participants who are part of this group. And the last bit is more focused on reproductive decision-making. So part of these people that have high-risk mutations are several risk-reducing procedures that can impact their family planning and reproductive health. So kind of looking at whether they've made any, have they chosen or are they thinking about any risk-reducing procedures such as an oophorectomy? Have they chosen to adopt instead? Are they looking at pre-implantation genetic testing and so on? So currently, the survey is under development by our data and Salesforce team. So that should be completed hopefully soon. And our goal is to get it out and be collecting data from these participants in August, and then looking at the data in September and October. So the potential impacts of the survey, I think, can go far and beyond just the scope of Wisdom. I think initially it's kind of like a needs assessment. Where can we as a Wisdom team work to improve the care coordination of people on our team? Can we provide additional resources to our participants that might need more connections to high risk centers? We can also potentially generate family planning and fertility preservation resources, since this isn't something that has been considered by the Wisdom study in the past, especially with the recent expansion. We recently also have been thinking about identifying whether we need a dedicated care coordinator, since a lot of our team at Color, which is the genetic testing company that we use, handles a lot of the counseling services. And finally, it's kind of to look at whether we can understand, whether our participants understand their risk and what actions they've taken and plan to take. and what we as the Wisdom team can do to potentially help them with whatever decisions they want to make about their health. And specifically with something like reproductive health, where I think there are around like 30 states that don't have specific guidelines in their insurance that provides coverage for people that have high-risk mutations for treatments like IVF and things like that. I think having this information is super valuable, especially for such a large study like Wisdom that's all over the United States. So yeah, that was my work this last year on developing this survey. And I want to thank everyone on the Wisdom team that helped me put it all together and come up with the ideas and how to implement it. And then of course, all of the BCC interns for being such great friends and all of your support through the last year.
Thank you. Questions from the audience while we're thinking about it? So it's interesting to think, so in New Zealand and I think Australia too, for certain genetically inherited mutations, Huntington's, chorea, BRCA1, BRCA2, and a series of others, they pay for 2 rounds of IVF and pre-implantation genetics if people want them. Can you imagine trying to implement something like that here?
Not with this administration.
But it would be very interesting. Where's Catherine? Should we put that? Perhaps we shouldn't put that into our symposium, but we could talk about it as one of the issues. All right. Catherine, question.
Wonderful presentation. I'm curious how you think the results of this could influence at what age we recommend women to get screened, because obviously like young women's breast cancer is really, really critical, especially right now, but also if you found this out at 25, like that has obvious implications on your reproductive health. So I'm just curious what you think about that.
Yeah, I think if we are looking at the participants and whether like their mutation status did significantly impact the decisions that they did make, I think it would open a conversation to potentially looking at younger populations as well, but haven't really thought about that.
That is the reason we moved it from 40 to 30, because the average, it's a little later than, I think the average age of having children has gone up quite a bit, but that's not the average age.
Oh, it's not.
Average age of pregnancy is not 38. I guarantee you. But I'll look it up. But anyway, but I think 30, that at least was our rationale for saying, the genetic testing doesn't change, you do it once. So we'll see though, but it's going to be very important to see what people want to do with the information, and we'll see if it varies by state. Okay, next up though, an important aspect. Thank you. Good big round of applause for Nandini. Okay, next up, we have a whole new way of looking at risk. And Olivia in Wisdom, and Olivia is going to talk about that.
Hi, everyone. Thank you so much for being here. I think I can start off with what I've learned this year. And I think I've learned really both the difficulty, but also the value of being able to kind of code switch with people in terms of the content you're discussing. I think, from speaking with patients about the trials I work on, with speaking with PhDs, they have very different expectations of the information you're trying to deliver. And it's really important to be able to kind of explain what you want to say in a lot of different contexts. And it's been a challenge, but definitely something that I hope to continue to work on in this next year. So as Nandini said, this is a project in the Wisdom study. We love the Wisdom study. And we are going to be talking about lifetime occupational exposures. Nope, I saw my next slide too early. Okay, so there's been a lot of research about environmental exposures in breast cancer. I think as Nandini showed in her slide, about 70% of breast cancer cases are sporadic, and often patients ask, well, how would this happen to me? And one influential factor that we're hoping to learn more about is research in environmental exposures in breast cancer. And so far, we do know that there are certain elements that women may be exposed to at work that might increase that risk of breast cancer. So all these lovely women in this cartoon are going to work, and within their workplaces, they might be exposed to ionizing radiation. So that includes military personnel, nuclear plant personnel, and a lot of nurses and flight attendants, anyone working in the flight industry. Toxic chemicals are often another common exposure. So nail salon workers, domestic workers, anyone working with really stringent chemicals. So that also includes nurses as well, and physicians, and everyone working in that hospital setting. And finally, we've also elucidated a protective factor of melatonin that is disrupted with night shift work. So nurses and flight attendants and people who work at the night shift may also be at an increased risk of developing breast cancer. But another really important risk cancer for breast cancer is time. Age is a really important protective factor. And as we've discussed, you can get breast cancer at any age, but it can take about 20 years for breast cancer to develop. And so for us, when we talk about occupational exposures at work, there isn't a specific time period that we can talk about. You know, we can't just say, oh, you worked in a chemical plant for a year. There's a whole career of different timelines that you might want to look at. And so for us, our research question was we needed to find a way to quantify people's exposure all the way through their entire life, a life course. So as you can see, there's been a lot of research between pollution, environmental exposures, and all of these things with breast cancer, but specifically within the Wisdom study, we wanted to see if a woman's cumulative exposures can impact the risk of breast cancer over time. So this was our goal. The first thing we did is we looked for a survey that already did this, that was already approved. It does not exist for the American context. We found one for the UK, but it didn't quite really work with what we were looking for. So we developed and piloted the WORKS questionnaire, the Workplace History Questionnaire, and we tested the reliability and validity of that survey and incorporated participant feedback. Again, ultimately focusing on that goal to establish cumulative occupational exposures and test the association with breast cancer risk. So we started with the whole Wisdom cohort. Wisdom has about 70,000 women. And they're all over the country with all different backgrounds. So we really wanted to make sure we got a diverse cut of this group to make sure that it was generalizable to everyone in the population. So we contacted recently active Wisdom participants, so people who had been on the portal in the last few weeks. And then 40 women responded. And then we were able to randomly select and invite a diverse group of Wisdom participants from all over the country. The participants then completed the questionnaire, and then our comparator here was an occupational history interview with an expert. So that's actually the gold standard of the industry for gathering an occupational history, especially a life course occupational history. But as you can imagine, with 70,000 women, we can't really schedule 70,000 hour-long interviews. So we wanted to see if within the Wisdom study, a questionnaire like this might be effective to gather that information. So the results between the two raters only agreed about half the time. I think we learned a lot in doing this, but I think the two methods were a bit different, but we did find some really interesting findings regardless. So older participants actually gave much more reliable answers than other age groups. Histories from people with first-degree relatives with breast cancer were also more reliable than other backgrounds, which I think has to do with the fact that they're probably a little more engaged with their breast cancer risk. And ultimately, we tried to, settle this mild agreement with following up with all the participants and seeing which of the two raters they actually agreed with most. And 70% of them agreed that the survey collected much more accurate histories than the interview, which then helps us say that within the Wisdom study, it's actually better for us to be able to use this survey than an occupational health expert interview to gather this data. So where are we going and why is this important? Ultimately, first of all, there's no validated survey like this. And so it definitely fills a methodological gap within this industry. And it helps us going forward to actually be able to estimate lifetime occupational exposures from occupational histories, which will be really important as we look on the whole Wisdom study-wide scale at how these environmental exposures might actually impact breast cancer risk. And finally, it does help us link occupation to health outcomes. So the relationship between lifetime occupational related exposures and breast cancer is still elusive. There's no smoking gun. There's no one chemical that causes breast cancer. But in looking at these broad swaths of exposures, it helps us kind of create a bigger and greater picture of how breast cancer can develop and become the issue that it is today. So finally, I would like to thank everyone that helped me all year on this project, especially Kim Vidal, who was my mentor all year, and Dr. Vantvier, Peggy Reynolds, Laura Esserman, and Allison, Francesca, Leah, Catherine, the amazing advocates who met with us every month and gave us lots of amazing feedback on the surveys, and of course the BCC interns. So thank you very much.
So, the link between environmental exposures and breast cancers, I mean, it's been looked at a lot, and there was just, several organizations devoted to it, sure that this was going to be it. The Marin Health study that found the main environmental exposure was white wine, but sadly, however, I think it's been a very complicated field, right? And really no smoking gun here. So what is, again, maybe try it to express why, do you think this is going to be more of the same, or do you really think this is going to be different, and why?
Well, I think we're really fortunate as researchers here to have the wisdom study in such a large cohort. I think when you talk about, research studies like this, gathering so much information, it's really difficult to be able to look at that data on a large scale and look at that big data analysis. And so I'm hoping that within the wisdom study, especially with such a diverse cohort of women that are a part of the study, we can find some really interesting and generalizable, results about, are there certain jobs? I know that there are certain jobs, as we said, that cause or increase your risk, but are there any regions or industries that might cause some sort of increased risk? I think will be really interesting. And I think because we have so many women that are so willing to participate in this study, hopefully we'll be able to make some really interesting.
Okay, well, what are the two things that are different that you're doing? Do you have an idea? It's not just the size, right?
Life course.
Well, life course, that's one, but we're looking, what do we have? What piece of
the methylation?
Well, we have genetic information.
Yes.
Okay, which nobody had before. So it might be, right, that you could only see it in the setting of people who already have one hit and have a high risk. So that might be really critical. And then there's a second thing. Well, methylation is one, but you're looking, how are you looking at what's different about the way that all these old studies were done and what you guys are doing? We can ask Kim to come in if you can't quite get it.
The geocoding?
Well, geocoding I think is important. Let's give Kim a microphone. Ask phone a friend. Okay.
Okay, so there's several things. So one, historically, when we're looking at jobs, so people would look at one job at a time, or they would look at one, like only nail salon workers, for example.
Yes.
But we're looking, so the life course part is actually very important, including when the mother was pregnant with them.
True.
So we're collecting the jobs the mother was working while she was pregnant, because we know that exposures in utero impact breast cancer risk.
Yeah.
So getting a full picture of your life course. And so what's different is the calculation of cumulative exposures over time, which has not really been done.
True.
As far as I know. And then we're going to look at gene bioenvironment interactions. So we're then going to see, okay, are there biomarkers of long-time exposures, right? Because you can't realistically do this in a patient, right? Like every patient who comes in, you can't realistically get their whole occupational history.
Yes.
So those are two things of many.
Well, and then the fact that you're looking at the toxic exposures in a very different way. So instead of one exposure, that's actually, I think, right? But, well, okay, I'm sorry, but eventually though, that's the idea, right? Yeah, because it's just like, because it's not usually one thing, it's like a cumulative thing, right? Okay.
And a lot of the research even the research I mentioned earlier about the jobs we know are related, a lot of the data we have about nurses is actually from a singular Danish nurses study where they only really discuss nurses at a certain period in their career working in the same place. And as Kim said, you know, a career is not a monolith. There are a lot of different types of jobs that people work throughout their whole life that could have an impact alone from just their main career.
Okay, let's have a round of applause for Olivia. Lots of exciting work to do. We are in the home stretch and weirdly exactly on time. Okay, of our modified schedule. All right, so Taylor has a very exciting new idea for how to think about risk and in women and maybe even a way to address it. So
hi all, my name is Taylor. This year I've been working on the Wisdom and Rise Up conference. So today I'm going to be focusing on Rise Up specifically, and something that I learned at the BCC this year. I think I want to echo everything that everyone else has said, and all the different ways that we communicate. But I think another thing I learned is that medicine is very political. We can see that with the way that this conference came about, related to protesting, going to conferences where they criminalize in states where they criminalize abortion. And then also, I think within Wisdom, we've seen a lot more influence of people's worldview and how they view reproductive health and that accessibility of it as they join the study. So as Wisdom was mentioned, and thinking about how we can approach personalized risk, the question begs, can we do more than just risk management? And so this is looking at secondary prevention of breast cancer with fibroids, breast cancer risk, and anti-progestins. So you might be thinking, how did we get to fibroids? This is a breast care center internship, and this came from the Rise Up conference, Revolutionizing Investigations to Step Up Prevention for Breast Cancer. And this conference really came about in rethinking how we can approach prevention with an eye towards the different time points in a woman's life where they might receive hormonal intervention. So from beginning with contraception and cycle control to IVF pregnancy and osteoporosis and hormone replacement in a postmenopausal setting, we can really see there's all these different opportunities to rethink this with an eye towards breast cancer prevention. And so at the Rise Up conference, there was a session focused on Black women's health and disparities that they face. And there was one expert who discussed fibroids extensively and how it really predominantly affects Black women and kind of the severity and impact that it has on them. There were also presentations focused on anti-progestins, specifically how mifepristone has been shown to reduce breast cancer risk by up to 50% in BRCA1 carriers, which I'll get into a bit more later. So these conference really sparked a lot of conversations on how we can incorporate and rethink a lot of these things. And so I'm going to be focusing specifically at the time point of fibroids and other reproductive conditions. So what are fibroids? Fibroids are benign growths in the uterus. They can be the size of a grapefruit or larger, and they can have different impacts like heavy menstrual bleeding, painful periods, just general pain, urinary tract issues, and pain during sex. And so what are the current treatments for fibroids? Unfortunately, there's not enough that are effective, long-lasting, and don't come with a lot of side effects. So we have gonadotropin releasing hormone agonists, something like Lupron, causes menopausal-like side effects and only temporarily shrinks fibroids. So it's important to note that after someone stops taking this medication, the fibroid does start to grow back in size. There's also medicines focused on symptom relief, thinking addressing pain, anemia, things like that, but they're not addressing the root issue, which is the fibroid, and it also doesn't reduce fibroid size. Lastly, we have minimally invasive and traditional surgery. So a myomectomy, which removes the fibroids, or a hysterectomy, which removes the uterus. This can have potential implications related to surgical complications, but also impact on childbearing. So as I mentioned, who do fibroids affect? Why do we care about this? Fibroids disproportionately impact Black women. They typically develop earlier, they are larger, have more severe symptoms. And the incidence of fibroids in Black women by the age of 35 is already up to 60%. And we see that go up to 80% by the age of 50. They're also diagnosed at 3 times higher rates than white women. And so they do impact women of all reproductive ages, all backgrounds, but we see this predominant effect in Black women. This is the current annual cost of fibroid treatment in the US, over $2 billion. This is primarily related to inpatient costs of hysterectomies. And so we can see that this is typically the route that people go down when they have recurrent fibroids because there's not an effective, long-lasting treatment. And this cost goes up because of that. And so in comparison, PCOS costs about $4 billion a year, and that's related to a lot of the long-term implications of PCOS. Polycystic ovarian syndrome. So again, to go back to anti-progestins, there's this drug talked about at Rise Up and something that's continued in a lot of conversations called ulipristal acetate, or UPA. There were studies done both in Europe and the US that looked at the long-term efficacy of this drug to treat fibroids. And important to note, not only was it seen to be effective in reducing fibroid volume and improving symptoms, even after they stopped treatment of UPA, the fibroids still stayed that lower size. And so even up to 6 months after treatment discontinuation, you still saw the fibroids stay at the size it was when treatment was finished. And then in another study following UPA treatment, only 54% underwent surgery compared to the 100% initially planned. So you might be asking, why is this not the new standard of care for fibroid treatment? And that is because liver toxicities associated with the drug that occurred in post-marketing data after it was already went through these clinical trials. And so the risk of liver failure resulting in liver transplant was seen to be 1 in 10,000, but there were also other liver toxicities associated with UPA. And in comparison, the risk of death from a laparoscopic hysterectomy for fibroids is 1.2 in 10,000. So I'm really highlighting this to show the need for newer and more effective treatment that also has that risk reduction in mind. As I mentioned earlier, mifepristone you might have heard of. It's typically associated with abortion, as also seen as an anti-progestin to reduce cancer risk by more than 50% in BRCA1 carriers and reduce in vivo the Ki67 of breast cancer cells. So for fibroids, mifepristone improves quality of life and associated symptoms, but it does not reduce fibroid size. So we see with these anti-progestins some sort of pathway that shows a lot of efficacy and promise in creating a drug that addresses fibroids. So here, progesterone and progestins are this pathway that seem to be the connection between breast cancer and fibroids. We know progesterone increases breast density, increases breast cancer risk, and anti-progestins reduce breast density and fibroid volume and can reduce breast cancer risk. The challenges with anti-progestins, as might have crossed your mind, has to do with politics and that association with abortion. Ulipristal acetate is also known as ELA for emergency contraception and a much higher dosage. And so these associations with emergency contraception and abortion have caused a lot of challenges in the regulatory space and in the research space to get these moved forward. There was a study done associated with the Black Women's Health Study that found a link between young women diagnosed with fibroids under the age of 40 and those diagnosed with premenopausal breast cancer. So instead of looking at just every woman who has ever been diagnosed with a fibroid or any woman that might have a risk of breast cancer, this cohort shows a lot of promise in identifying those at high risk for breast cancer who already have fibroids and how we can treat them in an effective way to really move this forward for both fibroid treatment and breast cancer risk reduction. So these future directions in clinical trials, as I mentioned, there's already been a lot of studies done on UPA and thinking about how we can reduce breast cancer risk along with that has come out of Rise Up. And so looking at primary and secondary endpoints, reducing symptoms and lowering rates of hysterectomies for those with fibroids, and then also using imaging endpoints and epigenetic markers to really look at that breast cancer risk reduction. So things like background parenchymal enhancement, which Sarah talked about earlier today, and then other epigenetic markers that were studied in that mifepristone BRCA1 study that was presented at Rise Up that has a lot of promise for showing how we can identify how and quantify how that risk reduction is actually happening in those cells. So the other option and the more promising one most likely is to use AI drug development to address the liver toxicity associated with UPA and redoing studies that show long-term efficacy of and safety with that drug in fibroids and reducing breast cancer risk. I just want to end with the take-home message that secondary prevention is the best path forward for advancing women's health. And this really comes from collaboration from researchers, physicians in different ways, and looking at how it's going to be cheaper, quicker, and more effective and reaching a lot more women. So save the date for Rise Up 2026, February 19th to 21st. And I want to say a big shout out to the BCC interns. Thanks for yapping with me all year. And thank you to Laura, Francesca, Kelly, Allison, and our Rise Up collaborators, Doug, Judy, and Carol.
Okay. How about that? You never know where new ideas will take you. So we're pretty excited about that, taking us down all kinds of secondary paths. Okay, somebody must have a question about this before it's just me. Who's yeah, there you go.
Amazing presentation. I had such a great time listening, and Rise Up seems really amazing. So I'm looking forward to working with you and on everyone's team. My question, I don't know if Taylor, you could answer this so much so, but in states that have been changing in politics, I guess, and you have sites all across America varying with these different political states. Have you seen more challenges with people willing to take a survey type study at all, I guess?
I think anecdotally we can, I mean, this doesn't really relate per se to Rise Up, but I think in Wisdom, there have definitely been a lot more participants who have reached out with concerns about sharing sensitive reproductive information with us, even though it's very like privacy and HIPAA protected. So I definitely think in my year, there's been a lot more questions, I think, about that, but I also don't know in comparison in previous years what that has looked like.
It's a good idea. I wonder if we could quantify that. Can we publish it? We could. Or we might want to be stealth for a little while. Anyway, no, I mean, just about, let's think about it. But we are planning to put in for a satellite symposium at San Antonio to talk about these issues. Catherine, do you remember what the 3 categories are? We just thought of another one today, right? Another 4. Do you know what they are? Give Catherine the microphone. Since we have to write it the next day or two. Better get cracking and helping us, right? Okay. Oh, actually, yeah, because we're going to do the whole thing about how many women are pregnant. Didn't you say it was like 1 in 1,000 women? So it's 1 in 1,000 women who are diagnosed with cancer are pregnant. Is that right? Yeah.
I think our 4 planned sessions is one about exactly that, like cancer and abortion, and that exactly
the two health threats, 2 life-threatening conditions. One is an obstetrical emergency, the other is cancer.
Exactly.
So, and how should we be thinking about this in ways that we make sure that no woman dies unnecessarily? Since we can all agree that we're all pro-life, nobody wants anyone to die unnecessarily. So for sure, we all agree on that. Okay.
Seems it shouldn't be controversial. And then we're going to do one on the NIH, like Medicare cuts, and then another on, would you want to say more? And then another on like sort of how to engage in advocacy in this time in a
Oh, we're not calling it that. We're calling it how to
public discourse.
How to improve public discourse. Yeah.
Yeah. And then 4 is about Rise Up, essentially what.
Oh yeah, and then Rise Up. Yeah. Yeah, to advertise. So get ready. Put on your running shoes. Okay, so anyone who wants to work, so that's Susie and Diane. We anticipate that you are going to be working on this satellite symposium with us. Okay, any other questions for Taylor? Michael.
I'm so sorry, Taylor. You're gonna hate me. No, really quick question, because I've seen on many posters around UCSF the PLUM study, which is studying the role of letrozole in treatment of uterine fibroids. So I just wanted to see what your study proposal looks like in comparison or in conjunction with the plum study?
I do not know about that study, but that sounds like people we should definitely be collaborating with. I know that I don't know how much letrozole has been looked at in the context of fibroids, but definitely could be an option. So yeah.
I mean, the problem with letrozole is, fibroids primarily happen in premenopausal women. Letrozole has to be given in conjunction with ovarian suppression. Both ovarian suppression and letrozole are pretty tough combination to take. So we're looking for things that are potentially more tolerable. So we'll look into it though. And, and letrozole is already, we know, something that will reduce breast density, but it's not something that women want to take. And again, it's mostly a postmenopausal intervention, not a premenopausal intervention.
I was gonna say, does it fall into the gonadotropin releasing hormone
You have to take ovarian suppression with it.
Right.
I assume, but we'll look into it. I haven't seen those in that. What are they in the elevator? All right. Well, I guess all of us should read the signs. All right. Big round of applause for fantastic presentations. All right. And now, of course, the best way to finish is to talk about OneSource, because OneSource affects every single project that we're doing in the BCC. And who better than Millie to tell us all about it? Okay.
We're going to have an anticlimactic pause very fast because I did do my slides on Canva. So we're going to pull that up real quick. Let's see. Note. Oh.
That can be reused forever.
That's going to be our yeah.
Stop share. There we go. Okay, here we go. Awesome. One thing that I definitely learned this past year is just to never be idle. I think if you're idle in this field, you're doing something wrong. Healthcare is just such a fast moving field and there's always places to learn. One example I can give as part of this presentation was developed in the past week, but we managed to pull it off. And I think that just goes to show you, I always walk away feeling so proud of myself and so accomplished when situations like that happen. So just frame your mindset to be positive and you can really achieve anything. So OneSource, I will be presenting on OneSource as a platform for structuring data collection to enhance clinic workflows and facilitate research. Let's see. Oh, there we go. As clinicians and clinical researchers know, and as the new interns will very quickly come to know, parsing through the jungle that is the electronic health record, or the EHR, is no simple feat. We've all been put in a position where we feel less like doctors or researchers and more like data archaeologists, where even finding a single biomarker result can take 10 to 15 minutes. Not only is this information difficult to find in the EHR, it could be in different places, it can be in a different system altogether. But when you do find this data, it's often quite variable or unstructured in free text notes. In addition, members of the clinic team often enter the same data elements multiple times over, which causes them to sacrifice valuable time for patient care. We can even extend this to research, as us interns know, where clinical research coordinators further complete the hunting process just to satisfy their research needs. So here we can see just how much of the data entry process is repeated on a regular basis. The green circles circled in red represent the entry of novel information into the patient's chart. The rest of it, all of the blue dots, are simply confirming, viewing, or updating that same information in the EHR. Let's look at one example of patient health history. As you can see, it's entered in very upstream in the new patient information. But then if we go all the way down to follow-up and research, we're still manually, painstakingly searching through the patient's chart to find this same information. But instead of look at this as a negative thing, let's look at those blue dots as opportunities for coordination in the clinic team. In other words, we're going to move away from a system in which each clinic member has to enter in their own full set of data for personal use, and instead work towards a system, work towards building a workflow where the clinician can easily see what information has already been entered and then add context as the patient progresses through their breast cancer journey. So we identified 3 main areas for innovation. First, we have data entry. Then we have clinic visuals, and last we have ancillary uses. The first that we'll focus on is the progress that we've made in streamlining the data entry process. So as many of you have maybe encountered, we have established a OneSource tab that is located in the Epic dashboard, which when clicked will open up to an electronic data capture browser so that you can enter in structured data at the point of care. This is achieved through HL7 FHIR, which is a set of standards which allows for consistent and efficient data sharing. And when you click on the tab, it opens up to that patient's page through single sign-on. Now that we've started to collect the data, the next steps are going to be in summarizing the data in a narrative style for right back into the EHR, which will allow for a very fast export that is trustworthy for future clinic notes. Awesome. So now we'll move on to clinic visuals. If we've entered the data, now how can we use the data? How can we manipulate that data? Here lies the current pathology sheet. And if I see new interns squinting at this sheet, I don't blame you at all. It's a lot of text thrown in your face. I know that when I started completing these sheets for weekly tumor board review, I spent as much time trying to figure out where to put everything in here as actually looking in the chart. Not only do we encounter the same concepts, the same issues that we experience with data entry as we're entering in this data manually into this visualization, which can take, it usually takes me at least a day, a whole entire day to fill these out. But after tumor board review, we reach a roadblock. This information becomes inaccessible as it sits in a shared drive silo that is inaccessible to the rest of the clinic team. So how can we make this all better? We partnered with Health Data Analytics Institute, or HDAI, to create a pathology timeline view, or a tool to view how tumor characteristics change over time and over treatment. So you can see here, we represent a patient that has had a core biopsy, then underwent 4 cycles of neoadjuvant therapy, then proceeded to the OR for a lumpectomy. A lot less information. It's so much clearer to see everything that's going on at a snapshot because in the blue, we have the general pathology categories with summaries. Let's say that you want to take a closer look. Maybe you're interested in the histology. You can use the telescoping function to expand the information and get more detail. Maybe you see under the invasive extent, the plus lymphovascular invasion, and want to know what's up with the dermal lymphatic invasion. Expand that section and you can get more information there. So you can see dermal lymphatic invasion, not present. Great. Now let's expand the entire list to see all of the data elements possible. You can see that we're not sacrificing any of the detail that we previously had. We still satisfy the College of American Pathologists synoptic reporting requirements to capture breast cancer data. The difference is we are simply allowing the clinician to choose which data they want, which details they want, and when. Lastly, let's collapse everything to just be left with the green boxes. Because we enter the data in a structured way, we can then automate a summary, which is then able to be copied and pasted back into clinic notes. So if we organize all of this information in a chronological sense with the patient timelines, now let's think of everything in a spatial dimension. As you can see here, we're no longer interpreting words in this scenario. We can clearly see what's going on. We see 2 breasts, one with an atypical lesion in yellow, and then another with 2 benign lesions in green, and 1 cancer focus in red. The idea here is that this visual is interactive. The clinician can easily hover over, say, the red dot and pull up a detailed snapshot of that tumor and its response to treatment. In addition, if we look underneath the breast map at the lesion list, we're taking all of the guesswork out of finding which pathology report goes to which imaging report, and instead it's all organized based off of the lesion and the time period. And really what we're doing with that is writing a story out of that evidence. Let's zoom out even further and combine all these concepts. If the EHR is a dashboard for the raw data, our one source dashboard is really a, first of all, source for the organized structured data, as well as a switchboard for all of these clinic tools that we have developed and all of the ones that are to come. Lastly, I will talk about the ancillary uses. And what I mean by that is just all of the uses of this structured data beyond the clinic. So recently, and this is the part that I alluded to happening in the course of a week or two, we created a linkage between the BCC pathology database created from our pathology sheets, as well as the UCSF tumor registry managed at Mount Zion. We were able to match the pathology data with the follow-up data based on MRN to study the survival probability over a certain number of days to see how tumor characteristics compare over time. So we matched the survival probability on the y-axis over a certain number of days on the x-axis to stratify the Ki-67 data. What we see here is that the green line, which is Ki-67 data below 24.5%, is associated with a significantly improved overall outcome compared to the Ki-67 data above 24.5%. And this is a known finding, but what's interesting is we proved this concept, and now we can apply this thinking, this Kaplan-Meier plot thinking, to any data point that we collect in the clinic, which is very exciting and can lead to an explosion of these research questions. In addition, another finding that we see here is that these error bars start to overlap around the 10-year mark, which is basically representing the accrual of follow-up data we have for the Ki-67 information. And what makes this important is that we are able to quantify the uncertainty, which is important for patients and clinicians when determining the long-term treatment choices. So that was a lot of information, a lot of different topics. And we described them very separately up until this point. We described them as very much their own categories, but I would urge you to consider them how they can work in unison. So one example that I have is, what if the Kaplan-Meier plots we just described could show up in the one source dashboard? What if you could see what patients with similar tumor characteristics, what their outcomes look like? In addition, what if the clinic visuals had live editing capabilities, which would inform the data entry portion? I think connecting to other topics that we've talked about today too, what if, for example, the PSC materials, what if the question lists were available in this one source dashboard? In addition, what if we could automate parts of the ROR process to help with the speed of that? I think that's what's so exciting. I hope everybody can see their own projects in one source. And I think hopefully you understand that we are all working towards one mission, working as one team, and we are building one source. Awesome. Special thanks, of course, to mentors, Dr. Esserman, Adam, Jasmine, Gary, Kelly, and Ali. And I just want to say I am extremely grateful for being put on this project. I know that it's an honor for Laura. This is her passion project to have chosen me to work on it. And I think we made some great progress this past year.
And come tomorrow and we'll figure out how to implement it before the end of the year. So Anna Northrup's prediction will not come true. Okay. Beware what you say at the BCC holiday parties. Okay. But come tomorrow and find out more about this. Okay. Questions. I hope all the new interns can see that this, or we can even ask Kenny since was in the clinic. Wouldn't it be amazing to have such a tool?
Yeah, it's insane.
Mike.
Yeah, I was saying it's insane. I was telling Josh the whole time.
Yeah, I mean, so you can answer questions, do things, know what's going on.
Exactly.
Yeah, and I actually learned the first time I sent the SWAT team out to find out where the new patient navigators, they actually have a page where they put data. I had no idea. Did you know? Yeah, where is it?
So we found this out during our patient interviews, and basically the way that they enter in this data, and it's organized wonderfully. It has screenshots, it has summaries, it's wonderful. It's entered into the exact referral that got them to the BCC and the referrals tab, which is very specific. And Laura didn't know that it was there. It's we can just streamline this process to where everybody isn't entering in data the first time. It's building off of each other. And not only is that efficient, but it's also leading to less errors, as we've all encountered.
Yeah, like the mantra in Silicon Valley is enter once, use many. The mantra in medicine is enter many, maybe use once. So well, we're going to change all that. But I think it's not just about facilitating research, right? It's facilitating what?
It's facilitating care. I think we see these, like I said, these subjects as very separate, but really this is all to benefit the patient. The patient isn't just coming to your clinic. The patient is also participating in research. The patient maybe wants to see this data. I think that it's important that we create this patient-forward, patient-encompassing source of data that, you know, if we're looking at the patient holistically, how can we represent them?
Or like, what do we call it? We're training you to do clinical practice. Well, what are you practicing for? Everyone should be practicing to be better. But if you're not, so whose job is it to look at outcomes and keep trying to improve? Is that like just the researchers? Is that a research function?
So I think that's interesting. I talked with Kelly, who very kindly, I'll give him the acknowledgement there, made the Kaplan-Meier plots for me to show. What is interesting about outcomes is right now I feel like we're looking at outcomes as something where we see research and maybe the research informs something clinical. So how are these research outcomes going to enforce something clinical? But we can flip the script on that too. What if we see outcomes that are not as well studied in the clinic, and how can that drive research questions moving forward? So it's really this circular pattern of how can we inform outcomes, but how can outcomes inform us in the clinic as well?
So again, I think one of the things is just seeing, you know, that yes, we can connect all our data to like the registry and find out, well, how, because again, we quote people what the outcomes are from the literature. But really, you should be able to quote what the outcomes are from who? Because they're coming to you for care. You should be able to look at your own data and say, hey, do we do better? Do we do worse? Do we do the same? Is this about the same? But I think there's a whole, it's challenging, right? So it's hard the data from the clinic is messy. It's been very messy, but it doesn't have to be. So the question is, how can we start to get it to be high fidelity learning? That's what real world data is. And real world data can be used actually for regulatory approval. And actually, the Oncology Center of Excellence is very interested in that, but we have to just make it possible. So that's the challenge, and figure out how to clean the data up and figure out how to ask the right questions. Not quite so simple, but possible. We should aspire to better, right? And to continue the conversations we have tomorrow, starting at 8:30, Sparking Innovation and Healthcare Value. That will be over at the conference center, and it's the Robertson room over at the Mission Bay Conference Room over across the way at the Rudder Center. Yes. Yeah.
So is it?
Again, we're going to get you the mic.
Is one source built specifically for UCSF patient data? And if so, are you able to integrate the data from UCSF's acquisition hospitals, like they acquired, I don't know, St. Francis?
We're doing a pilot right here, but I mean, obviously, the first place we could extend it is ISPY Wisdom to all the 45 sites. There's actually already a site that wants to use it, even though we haven't finished implementing it.
So will it be able to integrate data from lots of different types of platforms, electronic medical records?
Yeah, not designed for it yet, but I mean, that's the idea. We need a middle layer, right? So there's no shortage of things to be done. That's why you're all here. This is job security. But it's only by working together as a team that we can make all this happen. I encourage all of you who are starting to make sure you know what everybody else is doing and find the connections. That is one of the reasons why, pre-pandemic, everybody, was in here every day. Then the pandemic hit and we are slowly but surely getting back to that. But I think we'll find this year that everybody being together and that hub of activity and ability to connect and ask questions. You have a question, you don't send an email, you stand up in your cubicle and find out where the next person is who has that question, who can answer that question for you. All right, well, we're so excited. I'm so proud of all of you. You guys did such an amazing job. Many thanks to Hope Timberlake for all her great work, to Francesca, thank you for being an amazing program director, and to my partner in crime, Jeff Belcora. And tonight we are meeting at your house at 5 o'clock. Is that right? If anybody needs a ride, I have 1, 2, 3, 4 spaces in my car. So just let Francesca know. Okay, sorry, I have to get on a Zoom call. I realize I'm late. Okay. Love everybody. Thanks so much to everybody and all the mentors and all of the interns. Fantastic job, all of you. What a great day.